Sorry for the slight delay. So first of all, on behalf of KONGU PEDICON, we welcome you all to Coimbatore. We wish you a very happy Independence Day. And to chair the first session, we have none other than our own Dr. Doraikannan, senior pediatrician, one of our very active IAP and IMA members. And sir is very passionate about yoga. And sir is an inspiration for all. We welcome you onto the dais, sir. And for the first topic of the day, we have Dr. Uma Maheshwari ma'am. So ma'am is a professor of pediatrics in Sri Ramachandra Medical College. And ma'am is a pioneer in IEM. Ma'am has done a lot of work in inborn errors of metabolism. And she'll be talking on beyond sepsis in neonates, unmasking IEM.
Very good morning to all. I'm Dr. Uma Maheshwari. I work as a professor and I head the Department of Neonatology in SRMC. So being a neonatologist, how I kind of got interest in IEM or metabolic disorder is during antenatal counseling, we did have few of the children with developmental delay whose parents are coming and asking for recurrence risk. So would the same thing happen in my child also or not? So that was the first question pondering around in our minds. So that is when I wanted to do some of the metabolic workup and got trained in Australia and started doing it. In the process, we started newborn screening in September 2016, extended screening in SRMC. So if you are all wondering whether you will ever see an IEM in your lifetime, the answer is yes, because this is one of the posters which we presented in a conference stating that whatever you are studying in book, in Nelson, for example, there are some few postgraduate students over here, if you are having the condition, the same condition is still there. So this is a 2-year data from our metabolic clinic. Name it any condition, MCAD or MSUD or pyridoxine dependent seizures, all are still there. So with the rare incidence, we still have so many children because of a lot of consanguinity and endogamous population, and these are our metabolic stars. So what is the objective of me today? So I have been asked to talk unmasking IEM beyond sepsis, because first and foremost diagnosis which we make in any sick neonate is sepsis. I have to agree with it because it is treatable. We need to think about sepsis. I'm not saying that you should not think about sepsis, but should we think only sepsis or should we think beyond sepsis? So the objective would be when to suspect IEM in a neonate, how to evaluate a neonate with suspected IEM, and how to manage. So when to suspect, there are some misconceptions which we need to really overcome here. So inherited metabolic disorders are rare. Maybe it is rare as but collectively they are common. Individually they might be rare. So IEM should be considered only when there is a positive family history. I would say a strong no to it, because majority of the conditions are autosomal recessive in nature, and only the parents are carrier state where they are hale and healthy. Maybe you might get a consanguineous history, but sometimes because of the endogamous population you may not get a consanguineous history also, but still it is common. So IEM mimics sepsis. Yes, that is a topic given to me as well. Yes, it does mimic sepsis, but you have to consider IEM workup in any neonate whom you are not able to explain. Something goes unexplained there. And also you have to think that IEM can coexist with sepsis. So the other misconception is it is difficult to remember presentation of each. I have to agree, yes, it is difficult to remember each presentation. What is the easy way out? Use an algorithmic approach. Do not go by individual presentation. If it is an hyperammonemia, take the hyperammonemia algorithm and evaluate. If there is a metabolic acidosis predominantly, take the metabolic acidosis algorithm. And also go from a broad staged screening test to a highly specified test. So sometimes one of you might kind of wonder that only few are treatable, why should I, take a great deal to fix this? It is not so. What are you going to answer a couple who are waiting outside your NICU? Everything went on smoothly to them. All their antenatal period was perfect, but they have a child who is having problem and admitted in the ICU. You need to evaluate and give them an answer. And also for genetic counseling for future pregnancy. So IEM is TMS is diagnostic of, you can diagnose IEM with the TMS alone. That is not so. You might have to do something more than TMS also. For example, there is an hyperammonemia. Your proximal urea cycle disorder will not be caught by your TMS. So when you classify IEM, it can be protein disorder, carbohydrate or lipid disorder. Protein disorder generally presents with what is known as intoxication. So what that does mean is, the classical example being alcohol. As the dose of alcohol keeps on increasing, the changes increases, which is very similar to that. As the metabolites keeps on building up in the body, that initially starts with lethargy, slight poor feeding and tripping into encephalopathy. So that is protein disorders. It can be amino acid disorders, urea cycle disorder or organic acidemia. So carb and lipid, we know that both are energy producers. So they present as either energy production or energy utilization. So when I have to categorize an IEM, it makes the job very easy. I categorize as category 1, 2 and 3. Category 1 is intoxication group. So the classical example, as I said, would be MSUD, methylmalonic acidemia, isovaleric acidemia and propionic acidemia, and also disorder of urea cycle. Group 2 is energy failure. They present with fasting. It can be acute or chronic. Involves whichever organ needs a high energy, like heart, liver, muscle, brain. So group 3 is storage and vitamin responsive. Storage can be peroxisomal disorder, with your Zellweger being the prototype. It can be lysosomal storage disorder, but the presentation in newborn is very rare, except for Slice disease, which presents as high drops. Vitamin responsive disorders, they can present in neonate. Multiple holocarboxylase deficiency or biotin-based deficiency, pyridoxine dependent seizures can present in newborn period. So there are a whole lot of clinical presentation in a neonate, but remember, they can also have a sepsis-like picture. So when we are categorizing, so to sum up, category 1 is intoxication group, which would include majority of the protein metabolic disorder, sometimes carbohydrate like galactosemia. Group 2 is energy failure, which is lipid disorder or carbohydrate like fructose 1,6-diphosphatase, which can very well present in the newborn period itself. Group 3 is storage and vitamin responsive, which includes LSD, peroxisomal and pyridoxine dependent seizures. If you have to remember very easily the presentation of IEM, you can remember this as ABCDEFGH. So acute encephalopathy, bacterial sepsis-like picture, cardiomyopathy, dysmorphism, enlarged liver, family history, jaundice, high drops and intractable hiccups. So remember this sepsis-like picture. Moving on to objective 2, evaluation of a neonate with suspected IEM and how do we manage. So we all know IEM is nothing but substrate getting converted into product, and you have an enzyme or cofactor. If this is deficient, there is intoxication. If this also gets converted into another metabolites, this also gets accumulated. So this is again intoxication, or the product is not there, so energy failure. So all these things are coded by gene or molecular. So you have an enzyme which is a protein, so that is why we always evaluate in a molecular fashion. Majority of the time, because of the availability of genetics, now it is reverse. Before biochemical, the children are coming with molecular evaluation as such. So what is the baseline you will do? You will do what is known as GALAC, which stands for glucose, ABG, lactate, ammonia and ketones. Plus you will do a plasma amino acid, TMS, urine organic acid, plus or minus enzyme acid. These are the baseline biochemical investigations. Of course, you should do a molecular analysis. Always case scenarios are interesting to pick up. So let us go through some of the scenarios which we have come across in neonates. So this is a term baby presented at day 17 of life with shrill cry with a jaundice level of 25, and there was vomiting on and off with poor weight gain. The provisional diagnosis was acute bilirubin encephalopathy, like anyone would think of. But why would a baby on day 17 presents with bilirubin 25 and having encephalopathy, and the sensorium is also deteriorating? When during the discussion we thought, okay, possibly we should think of IEM also, because there is something unexplained here, and the MRI did show basal ganglia hyperintensity. So this is the MRI picture which shows a diffusion restriction in the basal ganglia. So we did a GALAC. So the GALAC showed an acidosis with the hyperammonemia and ketones were positive, which is suggestive of organic acidemia. So you take an algorithm, which is hyperammonemia algorithm. So this is symptoms after 24 hours and there is acidosis. So it is suggestive of organic acidemia. So that way things are very easy to evaluate. Investigation, the blood urea nitrogen is high. This is again one more parameter for you to differentiate between hyperammonemia due to urea cycle disorder and hyperammonemia due to organic acidemia. In your urea cycle, urea is not produced, so burn will be low. So the TMS showed elevated C3 and the metabolites are suggestive of propionic acidemia. So this is a quick chart for the PGs here. If there is an acidosis with the hyperammonemia and ketones, the diagnosis will be organic acidemia. If there is respiratory alkalosis with the hyperammonemia, the diagnosis is urea cycle disorder. But remember, when the baby is very sick and going to die, all babies will have metabolic acidosis and lactic acidosis. Whatever we are talking here is only during the initial presentation when they are presenting as lethargy. So when there is an hypoketosis with hypoglycemia, so it is suggestive of fatty acid oxidation defect. If there is a lactic acid which is very much elevated compared to all the other parameters, it is suggestive of primary lactic acidosis, which would include your pyruvate dehydrogenase and pyruvate carboxylase. Sometimes pyruvate carboxylase can also have hyperammonemia. So again, the next one is GALA being normal, which is glucose acidosis, lactate, ammonia is normal, but you have ketones alone pouring out in the urine and blood, that is suggestive of maple syrup urine disease. So this is a very quick card which with the GALAC itself you might be able to come to a fairly good diagnosis. So the baby over here, like we had evaluated and it showed a mutation in PCCA gene and admitted with multiple crises, managed with the special milk and special formula and breast milk. So this is the child. So treatment modalities, very simple treatment modalities in IEM. So this is one of my favorite slide. So you decrease substrate availability, you provide deficient metabolites, you increase the enzyme activity, or you increase the toxic metabolites. Disposal of toxic metabolites. That means you remove the toxic metabolites. So if you apply this particular management principle in any IEM, you will be successful. It can be any IEM, it can be LSDs, it can be vitamin responsive disorders, it can be biotin deficiency. You just have to apply this principle. So how do you apply this in propionic acidemia? Just now we had a baby with propionic acidemia. So in long term, you put on low protein diet, vegetarian diet. You give on metronidazole, which reduces the hot chain fatty acids in the gut, thereby reducing the substrate. You do a hemodialysis or hemodiafiltration in initial stages. Sodium benzoate can be used, but it should be cautiously used in organic acidemia. Remember, isovaleric acidemia, glycine is the main chelator. If you give sodium benzoate, it can chelate the glycine and worsen the condition. So whenever you are thinking of organic acidemia and you have a sweaty feet order, your diagnosis should include isovaleric acidemia. That time, do not put on sodium benzoate. For other organic acidemia, you have to be very cautious. Carnitine you can supplement, again that is to make excretion of the toxic metabolites. Biotin supplementation should be done. So what is the pearl you learned from this? Get ammonia level whenever you have something which is unexplained. That might twist and turn the situation. Bund helps in differentiating and follow the management principles. So moving on to case 2, this is firstborn of third degree consanguineous marriage, discharged on day 3. Day 9, irritable, hypertonic, lethargy. So initial evaluation, ABC, euthermia, euglycemia, correct electrolyte imbalance. We would put on antibiotics because sepsis is something which is treatable. You will not be courageous enough not to start on antibiotics, but you should think of IEM. So the usual management principles you need to follow in terms of promotion of anabolism and preventing catabolism. So the GALAC showed GALA normal with ketones positive. So quickly we can do an MRI with MRS. Here the MRS showed elevation of branch chain amino acids at 0.9 ppm, which is suggestive of MSUD. And the MRI picture in diffusion restriction is also showing a double swan appearance, which again is very characteristic of MRI. Sometimes we find difficult for the TMS report to get it on time, but MRI and MRS, many of the institutes we can mobilize. So we should consider MRI with MRS in any child presenting with encephalopathy. So same management principle, you have to keep nil protein, but quantified amount of breast milk should be started after 24 to 48 hours. Thiamine supplementation, hemodiafiltration or peritoneal dialysis, high energy in terms of high GIR, insulin if needed, fluid balance and bicarb. Lipid can be added if you fairly exclude fatty acid oxidation defect. What is more important, many of us know this acute management, but we do not know when to start on feeds. Only 24 to 48 hours the baby can tolerate nil per oral or without protein diet. After 24 to 48 hours, at least quantified amount of breast milk should be started. Why I am insisting on that? That is because majority of the time they go catabolic, the muscle mass itself disintegrate and increases the ammonia. We will be thinking, okay, the metabolic thing we are not got in top of metabolic crisis. So you will prolong the nil per oral. So it becomes as a vicious cycle. To break the cycle, you must introduce some protein. You have, once the baby is in ICU, you have your dialysis or hemodiafiltration to remove the toxic metabolites. So do not worry about, little bit of protein over there. That is essential to promote anabolism. And also remember this Taraga mantra, if gut is working, use the gut. So do not starve the child, the villus atrophy will happen. And also many of us will think breastfeeding is contraindicated. It is not so. Breast milk has a lot of nutrient advantage. So all amino acids are lower compared to formula feeds and it should be started as early as possible in the crisis. So even if you see here, the leucine levels are quite less in human milk compared to cow's milk. So this is the leucine, isoleucine level in TMS. So same thing, along with that we supplemented carnitine because carnitine has been shown to be antioxidant property. So this is the baby who was in crisis. You can see the hypertonia, the baby is in arching. Same baby on follow-up on the right side. Who said IEM cannot be treated? You can treat IEM. So IEM and diet is an inseparable combo. So you have to have your very simple amino acid disorder, put on amino acid formula, but continue breast milk at least 50%. If it is an organic acidemia and urea cycle disorder, majority of the time they will be able to tolerate the breast milk along with some high energy formula. So basically breast milk along with special formula, it is available in India itself, and you can have IEM foods in later on stage. So this is a follow-up chart which shows a reduction in leucine level to the required amount, which is 400. There are charts for different conditions what should be the target amino acid levels. So anything more can be done in MSUD. There is a liver transplant option because that is the one which increases the enzyme activity. So before liver transplant, optimize nutrition. Make sure that you are not giving any false hope to the couple over there. You have to say that whichever neurological dysfunction has already happened, you cannot reverse. Ongoing damage can be prevented. So you have to consider, is IEM potentially curable by liver transplant? is the severity of IEM in terms of recurrent crisis, having a poor quality of life warrants liver transplant. Any other, all the systems are preserved or not, and do parents agree and consent? So what is the pearl you learned from here? Not to keep nil per oral longer than 24 to 48 hours, importance of breast milk, and also monitoring amino acid levels. So case 3, I'll make it very simple. This baby had a UTI, E. coli proven UTI, thought to be protein metabolic disorder and referred. So whenever started on breast milk, the ammonia creeped up. So we did a basic bedside examination, namely red reflex. The red reflex was absent. There was hepatosplenomegaly, which made us think the diagnosis of galactosemia. So remember, galactosemia can also have hyperammonemia as such, and it was proven in terms of GALT enzyme, there was a pathogenic variant. So what is the pearl from this particular case? Clinical examination is important. Cataract in terms of red reflex should be monitored or looked for in any neonate, and hyperammonemia could be due to liver dysfunction, and E. coli UTI coexist with galactosemia. A simple case 2, this is a energy failure. The baby presented with transient hypoglycemia. So later on had seizures and encephalopathy, hypoglycemia, deeply comatose. So suspected IEM, GALAC was done, glucose was low and ketones were absent. So that made us suspect fatty acid oxidation defect. There was a serum, lipemic serum also. So how do we manage? Same management principle. There is something called as BAMDG guidelines, which is British Inherited Metabolic Disorder guidelines. So take that guidelines, calculate the fluid according to that. So this is going to be a tool which is there. So the report is suggestive of what is known as CPT1 deficiency, which is one of the fatty acid oxidation defect. So same management principle. Instead of protein restricted diet, you will go on to a lipid restricted diet or modification of lipid. So dialysis should be done in acute stage to promote to remove the toxic metabolites. Glucose or cornstarch can be used, and we can use something like cofactors like bezafibrate or alternate substrate like triheptanoin. But remember, carnitine sometimes can be harmful in long chain fatty acid defect. So there is a treatment consensus group which also recommends that you should not give carnitine, IV carnitine just like that in a long chain fatty acid. Remember, when you are discharging the baby, you have to educate them that the neonate should not faster more than 3 hours at any stage. So this is a child on follow-up. You can see the child who is deeply encephalopathic, having posturing, even talking about withdrawal of care, had done well after appropriate management, and this is a recent picture of hers. So emergency management, only remember this, hypoglycemia is a late event in FAOD, so do not wait for hypoglycemia. So management wise, avoid fasting and avoid fasting. What is the pearl from here? Carnitine you have to use judiciously, and hypoglycemia is a late event in FAOD. A quick case on group 3 disorder. So this is a non-consanguineous couple referred from another tertiary care institute with a refractory seizures on since day 5 of life. We received the baby on day 8. One particular history we elicited because she is a G2P1L1. So we elicited whether the mother perceived increased fetal movement. She said yes, there was increased fetal movement compared to the previous baby. This is a MRI picture which showed hyperintensity in the MRI, and MRS showing lactate peak, and bedside EEG showing burst suppression pattern. And this is very much suggestive of pyridoxine dependent seizures. The CSF, we did what metabolites known as AASA, which is alpha aminoadipic semialdehyde and pipicolic acid, both were elevated and phenotypically confirmed. So pyridoxine was started appropriately on the day 2 of admission, initially orally, then we gave IV also. So this is the baby at 3 month, 11 month and present age. So pyridoxine is available as Neurokine Gold, not that like it's one particular brand, but this is the only IV preparation available as far as I know. And even the active form is available as Tetrafol Plus, which contains pyridoxal 5-phosphate, which has to be started if the baby is not responding to pyridoxal. So what is the pearl you learn? History taking skill is important, and also trial of pyridoxine in refractory seizures. Slide on newborn screening, you can prevent all this alopecia, skin changes. If you are screening for biotin-days, right is a baby who has been screened in for biotin-days and having a developmentally normal child, whereas left side picture is showing some problem due to biotin-days deficiency. If it is a preventable disorder, why don't we screen? So these are the BAMDG guidelines, which is very useful. You have a temple tool for parents, that is also very useful guide to explain to the parents. These are some of the resource materials which you can use in your day-to-day practice. And this is also one of the good resource material, Vidamecum Metabolicum. So take home, any unexplained, please think of IEM, a thorough clinical examination. Don't forget about your history taking skills. Biochemical, GALAC followed by TMS and GCMS. Do a flow chart, simple principles. So protein diet, you have to initiate within 48 hours. Do not think breast milk is contraindicated. And team effort, we can achieve more. Thank you.
Thank you very much for an excellent talk, both in the sepsis in neonates and unmasking AAM. We'll have a question hour after your next topic. I request Dr. Srinivasan is going to talk on hypoxic ischemic encephalopathy. The challenges, the severe cases. We know HE is a basic brain injury resulting from the oxygen and blood flow deprivation. HE is an umbrella term for brain injury, happens before, during and after the birth, where oxygen and blood is stopped. Severe complication leaves with more of neurological deficit, and Dr. Srinivasan is going to talk about the third, that is severe form, stage 3. Thank you, sir. Over to you. Madam Uma Maheshwari can come and occupy chair here. I think I have not separated you.
Good morning, everyone. Today I've been given the topic of ethical issues during the management of HIE babies. A bit complicated because still we are not knowing what exactly to be done, especially in severe hypoxia and mild hypoxia. So what is HIE? It's a perinatal asphyxia, which refers to the critical interruption of oxygen, which leads to hypoxia, critical decrease in blood supply, which leads to the ischemia, and the resultant brain damage, which results in significant resuscitation needed at birth and subsequent management. So here the resultant brain injury results in altered state of consciousness, abnormal neurological findings, and seizures can occur typically subsequently. And the predictions here with severe hypoxia is very difficult. So it's because with HIE, various babies goes in different ways, and it's a big challenge to predict what exactly to be done, especially in severe hypoxia. So in simple way, HIV is described as hypoxia as not enough oxygen, ischemia is not enough blood, and encephalopathy is a brain injury. So coming to what exactly is the incidence of HIE? In Western countries, it's almost 1 to 3 per 1,000. And in low and medium resource countries, it's almost 20 per thousand. In India, in southern India, it's about 10 to 15, and in northern India, it's around 20 per thousand. So this HIE accounts for almost 1 million neonatal deaths globally. 50% of them are very severe and 50% die because of the complications of HIE. Among the survivors, 20% will have major disability, and in these babies who don't have any major disability, almost 70% will have a minor disability in the form of autism or behavioral disorders. So coming to the pathology, so once the insult happens, there is a significant hypoxia, which results in a primary energy failure. We all know that in aerobic glycolysis, each molecule of glucose can give around 36 to 40 ATPs. Same thing in anaerobic glycolysis, it will give only about 2 to 4 ATP molecules, which is almost 20 times less. Therefore, there is an acute shortage of ATPs, which disrupts the ionic balance of the cells. Therefore, there is a lot of gush of sodium and calcium intracellularly, and which causes complications in the cell, and cell death and seizure disorders can happen. So next comes the reperfusion. This is more dangerous. During the reperfusion, there is a sudden perfusion back into the system, and the damaged tissues are not ready to take up all the oxygen. Therefore, there is an excessive free oxygen radicals which are created, and also per-hydroxyl radicals, which could be more detrimental in the presence of xanthine oxidase, which is liberated by the endothelial cells which are damaged. So here next, this goes on to the cellular injury. Caspase is activated, which results in cell death by apoptosis. So during treatment, what are the different options? In the initial stage, during resuscitation, we have to give prime importance for proper resuscitation. Here in HI insult, there is decreased oxygenation, increased CO2, there is a decreased pH and decreased ATP. Whatever possible, we have to combat and correct these complications. And we know that there is a primary energy failure, so you have to accordingly adjust these babies and support these babies with whatever they require. And then we got the latent phase and the secondary energy failure time. This is the time where we can offer some treatment for these babies and restrict the damage to the brain. And subsequently in the tertiary phase, that is remodeling stage, the occupational therapy has got a major role. We all know that newborn babies' brain is significantly neuroplastic. So they can modify, all the existing cells can take over the functions of the destroyed cells. So if you properly give occupational therapy to these babies may come out reasonably well. So HIE is classified as mild, moderate, and severe. In mild, we don't have a second thought. We are not cooling as of now, but there are some evidence even mild HIE could be cooled. I'll talk on those in the subsequent slides. So generally mild, only less than 1% die, maybe because of improper resuscitation. And 95% have a good neurological outcome, and 5% may have mild degree of abnormality. Moderate to severe, they have got reasonable amount of damage. So the standard care is therapeutic hypothermia. So best outcome is for the moderate HIE and some benefit for the severe HIE. So here ethical dilemma is which baby should be cooled. Can we cool all the severely hypoxic babies? Because still the outcomes are not good even with cooling therapy. We end up in having almost 80 to 90% of neurologically abnormal baby. So do we have to cool these babies? But some parents may be ready to take care of the babies even if they are disabled. Some parents don't want any disability in their baby. So discussion with the parents will be a primary role before we decide on this treatment. So here for prognostication of the outcome in extremely difficult, then clinical assessment is very important. Delayed onset of symptoms and early recovery generally have a good outcome. Presence of severe encephalopathy even after 72 hours of cooling is a bad sign. Brain MRI, which shows involvement of the deep gray matter, that is basal ganglia, especially the globus pallidus, can have a strong association with the cerebral palsy. And brainstem involvement, there is a high degree of disability in the later stages, and also the death also is quite high. But none of these criteria which I explained is definitive because it changes with each baby. So some babies may do well even with severe hypoxia, severe disability, with proper occupational therapy and proper training. So this is another ethical dilemma whether to cool or not cool all these babies. Managing HIE. Here again it involves a lot of things, whether life-sustaining treatment has to be given for every baby. Do you think this baby is going to come out well? Will this baby have a good quality of life? Are the parents ready to take over the baby if there is any neurological disease? All this has to be discussed. So again, the dilemma involves balancing the neonate's best interest. Suppose we think this baby is going to have very bad outcome and the parents want the baby to survive. Are we doing the right thing for the baby? Baby can be suffering lifelong. And wishes and values of the family has to be respected, because primarily the baby is parents' baby. So we have to take their opinion before deciding on anything. So here, once we start therapeutic hypothermia, initially we cool the body to about 32 to 34 degrees centigrade, maintain the cooling for about 72 hours. And during this period of cooling, the metabolic rate slows down. Therefore, there is rest for the cells to recover. And then subsequently, after the recovery, brain cells slowly start recovering. And this again depends on what management you give afterwards. That is very important. Follow-up and occupational therapy forms a very important aspect. So standard treatment is in severe HIE, moderate and severe HIE is cooling always. Now we have got enough evidence that all babies with moderate to severe HIE has to be cooled. It decreases the cerebral energy metabolism, decreases free radical production, and decreases the glutamate release, which increases the calcium influx and causes seizures and cellular death. It also increases the N-acetyl aspartate, which is a brain protective one. It also conserves the protein synthesis and preserves antioxidants and the cerebral ATP which is needed. So eligibility criteria must be met. So Sarna stage 2 or 3, baby should be more than 36 weeks of gestation, less than 6 hours post-birth. There should be a history of Apgar being less than 5 at 10 minutes, positive pressure ventilation or chest compression for more than 10 minutes, an acute perinatal event, a cord pH of less than 7, and a base deficit of 16. So if these criteria are fitting, you can start cooling safely. If cord pH is not available, you can do an arterial or a venous pH within 1 to 2 hours of birth. And if that is suggestive of, again, acidosis with a pH of less than 7 and with a base deficit of minus 16, then again you can offer cooling. So these are the normal equipments needed during cooling in the well set up units. So these are a warmer with an automated cooling system with an amplitude integrated EEG, NIRS to check the perfusion of the brain, and also other monitorings like BP. So primary principles of cooling, resuscitation is the top priority. So think about good resuscitation at birth before you go on to the cooling. Cooling is an adjunct therapy. Cooling can be started in the peripheral hospital, preferably as a passive cooling. Continued management must always be done in a tertiary care NICU with good facility and with good nursing care. Counseling and discussion with the patient's parents must happen before cooling, because you will end up in trouble because a lot of legal issues and ethical issues. So what do you resuscitate during cooling? Even if the baby comes out totally flat, you start resuscitating with air. This has clearly shown that resuscitating these sick babies with air decreases the death by almost 30%, and even there are other benefits when you start resuscitating with air. Only if the heart rate doesn't improve, even instead of adequate resuscitation, then you can start using oxygen. So air or oxygen during resuscitation, now there is no doubt that we have to start with room air resuscitation. So to cool or not to cool, we have to cool in moderate to severely asphyxiated babies without any doubt, because we know that there are significant benefits. Stabilization on admission is very important. We have to take care of these babies, and all the nursing care should happen appropriately. Whatever the baby requires should be done. And generally recommended is 1 nurse per baby. At the most, 2 babies can be looked after by 1 nurse if the babies are stable. If the baby is sick, 1 nurse should be there for each baby. Babies have to be monitored regularly. Supportive measures like whatever the baby requires, like glucose, the inotropes. If the baby requires extra support, you will have to give. Prevent SIADH, restrict fluids, prevent hypoglycemia, prevent hypomagnesemia. All these have got neurological outcome. So whether to feed or not. This was a controversy till last few years, but now there are enough studies to say that feeding is beneficial in these babies, but it should be only trophic feeds. Because in hypothermia, the vasculature is constricted, there is no enough blood supply in the gut. If you give too much of fluid, this is one condition which can lead to neck even in a term babies. So feeding should be only trophic feeds to keep the gut active, and there are other benefits in feeding also. So look after the coagulation, because whenever you cool, these babies' coagulation can get disordered. So unless you look regularly, you may miss, and suddenly baby will present with a severe hemorrhage and die. So you have to take care of this. A meta-analysis for the feeding shows that trophic feeding is beneficial. Time to reach full feeds is shorter if you have started trophic feeds, because you are keeping the gut active. Potentially, it reduces the sepsis and also mortality. So this is the outcome of that study, which showed a beneficial effect. It decreased the PPHN, TTN, and also decreased the duration of mechanical ventilation, and decreased the chances of hypotension in these babies when enteral feeding was started. You may think what it is. It's all because of the gut-lung axis, gut-brain axis. Gut is connected to every organ. So that's why feeding has got some effect on each organ. Rewarming also is not risk-free. You have to take care of the rewarming, and you have to follow the correct steps of rewarming. Only then, otherwise you can end up in trouble even with rewarming. There are chances baby can go for hypotension, hypoglycemia, bladder atony, coagulopathy can occur even at that time, rhabdomyolysis, ventricular arrhythmia, seizures. All these are known to happen if you rewarm very quickly. So correct methods has to be followed. A meta-analysis of 1,322 babies also show that therapeutic hypothermia can cause significant side effects or toxicity. Cardiac arrhythmias, sinus bradycardia is noted in almost all babies where we cool, but ventricular arrhythmias can happen. You have to be very careful. So monitoring the electrolytes also will be very important. In hypotensive babies, you have to treat the hypotension. Thrombocytopenia is a potential complication. So look at the counts daily. And metabolic dysfunction also can happen, like acidosis, hypokalemia, and hypoglycemia. Treat accordingly. So each time, whatever you do, risk versus benefit has to be considered. These are all ethical dilemmas. On the pulmonary also, it can have its own effect because it causes pulmonary vasculature constriction in a cooling. This results in pulmonary hypertension. So it can also decrease the surfactant dysfunction. And pneumonia secondary to, again, increased infection can happen here. And these are all the problems with cooling. So do we cool again? But risk versus benefit, cooling is definitely beneficial. And if the baby, all these things has to be communicated to the parents also. Otherwise, parents may start blaming that my baby got sick just because you cooled. So all these has to be communicated prior. But most of these complications can be addressed with proper treatment. So these are another complication, subcutaneous fat necrosis, which can result in hypercalcemia, hyperlipidemia, and thrombocytopenia. Again, is it an ethical dilemma? No, you can always prevent with a proper nursing care. HELIX study, this I had to tell because this was a big study in 3 countries, India, Bangladesh, and Sri Lanka. Therapeutic hypothermia was started in tertiary care centers, but remember 70% of these babies were born outborn. Primary outcome, that is death, that is composite outcome. Death, moderate or severe disability, there was no significant, but only in the death, they found that there was an increased death in the cooled baby. So the only study which showed increased death in cool babies was, but this was a large study, we can't neglect this also. But the conclusion was therapeutic hypothermia should not be offered as a treatment for HIE in low and middle income countries. A blanket statement as above, is it appropriate? Even the NNF has not agreed with this, so there is controversy. Some of the drawbacks which I went through in the HELIX study was, it was an open label trial, it was not masked, the chances of bias will be very high. 70% of the babies were outbound, and all these studies were done in government hospitals, where though we have got good doctors, good equipments, generally there is a limitation of nursing care and also medical care. And nurse allotted was 2 to 4 patients were allotted for each nurse. That itself is a bit compromise in this study. Passive cooling was not allowed till admission because initial passive cooling, at least it can minimize the damage to these brains, and it's not going to affect the babies because these are all term babies. The effect is not too high. It may be protected in doing a passive cooling initially till they reach the tertiary care center. And only 30% of the born were born at the treating hospital. And one more thing I noted was sedation was not used here. So generally, these babies will be a silent sufferers because their brain is damaged, they are not active, they won't be responding, but they will be silently suffering the pain. Studies have shown that if you don't give sedation, the outcome is bad. So these are the problems with the helix study. Again, when I went through the helix study, I found that only the death was bit high in the helix study. All other conditions like severe disability, survival without neurodisability, persistent seizure disorders, and disabling cerebral palsy, they were all having a trend towards cooling was better. What about mild HIE? The conundrum is whether to cool or not to cool. The main problem now is in Western countries, most of them have started cooling because some of the studies have shown that almost 20% of these babies, or in some cases even up to 50, can have some decreased IQ later because of the mild HIE, and this can be minimized. But we don't have enough evidence for that. This was a systematic review which showed that abnormal neurodevelopmental was seen in almost 10 to 30% with mild HIE, but they were all milder variety. So there was an MRI changes at 9 to 10 years, they had a lower IQ. And also there were some increased behavioral issues. So there is a big COMET study which is going on, which may give us a better picture whether to cool with this mild HIE or not. This is a multi-center trial done all over the world. 52 hospitals are included, 520 infants are included. It's a 2-year neurodevelopmental outcome will be assessed, and these results may guide us what exactly we should do in mild HIE. But wherever you are in doubt whether it's a mild moderate, it's better to start cooling and then make a decision whether to stop the cooling or not. So this is just 2 case scenarios because of the ethical issues, whether we to cool or not. It's a 40 weeks gestation female infant, born by emergency cesarean, weighing 3.5 kilo, extensive resuscitation at birth, intubation, adrenaline, cardiac massage, everything was given. Upcars were low, intubation on admission to NICU, cord arterial pH was 6.7 with a base deficit of 20. So here we don't have any doubt this is a severe HIE required therapeutic hypothermia. In the second case, what to do in a therapeutic hypothermia or observe in this following case. 40 weeks gestation male infant, forceps extraction, birth weight was 4 kilo, bag and mask ventilation was given for poor respiratory effort. Upcar scores were reasonable, though it was 5 at 5 minutes. Cord arterial pH was bad, pH was 6.9 with a base deficit of -17. So admitted to NICU, but baby was alert and responsive. So with this, what we do, there are criteria which tells us whether to cool or not to cool. So since the baby was alert and responsive, this case was from Australia. What happened, baby was very alert, sent to the postnatal ward at 7 hours because baby was active. At 12 hours, baby developed seizures. Day 5 MRI showed occipital changes. At 2 years, diagnosed with cerebral palsy. So here there was a lawsuit, failure to provide hypothermia for these babies, and almost $5.3 million compensation was given. So withholding or withdrawing life-sustaining treatment. In severe HIE cases with poor prognosis, discuss with the parents and make a decision. Both clinicians and families should be taking a decision simultaneously. So sometimes you may have some controversy between the parents and yourself. You may think baby is going to be very bad, parents want continued care. All this has to be discussed. For this, ethical committee in the hospital will be very useful to make a final decision. And there is a window of opportunity. When the baby is sick, it's easy to withdraw the care or stop treatment. But once you miss the window of opportunity, in India, euthanasia is not allowed. Determining the quality of life also is important, whether the babies will have a good outcome later. Parental decision making has to be given prime importance. Religion may play a significant role. In some of the religions, they will never withdraw care, whatever. And there were few cases, even in Australia, we had to go to the district centers and then we had to convince, and we took the permission from special authorities, only then we could withdraw the care because the religion will not allow them to withdraw. So again, balancing between beneficence and maleficence is very important. So whatever is beneficial to the baby should be done, and what is going to harm the baby should not be done. I'm just going quickly with some more slides. Legal implications also we have to be aware. So if there is a negligence, IPC section 304, you may end up in trouble. Withdrawal of life support without proper documentation and safeguards can end you up in trouble. There are different sections which can cause problem. Institutional protocols and legal reviews will be useful. Last slide. India does not have yet a comprehensive law governing end of life for newborns. Draft euthanasia bills and palliative care policies have been proposed but not enacted. Do not attempt resuscitation has been allowed in India. So I think I'll go to the last slide. Summary and recommendations. In a level through NICU trained team, early referral cooling is strongly recommended. In a proper inclusion criteria with moderate to severe HIE less than 6 hours, cooling is recommended. Lack of monitoring recommended. No risk is too much, you should not be cooling. Outside protocol, that is if it is not fitting into the protocol or if it's a mild HIE, do not cool. Without getting the consent of the family, never do the cooling. It violates the principle. Thank you.
Thank you, Dr. Srinivasan, for an excellent talk on HIE. Please come and occupy the chair, sir. Srinivasan, sir. It's time for discussion. As such, the only approved is the cooling for HIE, but there is a legal complication. It is a preventable disease, it's not prevention is better than cure. So, a good atmosphere, good perinatal care, good labor room, and good pediatrician by the side of the delivery always prevents most of these complications. Over to the question of anybody who wanted to ask any question on HIE? Mike. What is passive? Okay. Passive cooling.
Okay, actually whenever the baby is born, you keep these babies under warmer. It is heated. You just don't heat the baby. Allow the baby to just be under the normal warmer without the warmer being on. And you don't want to wipe out all the liquor, everything. That will give the temperature about 1 degree less for this baby. That itself may be sufficient enough to decrease the nerve damage in these babies. Yeah, steroids, especially when you suspect there is steroids has got a role, and it's known to improve the neurological outcome. But again, risk versus benefit. If you are suspecting an infection, steroids may not be role. But especially when you are having problem with hypotension and hypoglycemia, you can use steroids safely because it will be beneficial. Some of the centers are routinely using steroids for neurological outcome.
How much, sir?
So hydrocortisone, normal dose 1 milligram per kilo per dose every 6 hours. We can go up to 2.5 milligram per kilo per dose every 6 hours.
Sir, can cooling prevent cerebral palsy?
That's what I told you. So generally, in summary, in mild HIE, cooling can prevent almost all problems with the neurological outcome in mild. In moderate, it's known to decrease at least by 50%. If it is not cooled, the neurological outcome is bad in about 15 to 25. If the baby is cooled, the neurological outcome will be 5 to 15. So it decreases almost by half. So cerebral palsy can be avoided, but you can't prevent in all babies.
Thank you, sir.
Thank you. Rest of the question, you can send the questions in our email, or you can ask at the end of the session. We got Dr. S. Ramesh is waiting. He's a hero of Coimbatore pediatrician. He's qualified MD, DM neonatology. He's a professor in PHI College of Medical College and experience in the neonatal ward alone 12 years. His major achievement is organizing camps, organizing meeting, and teaching the youngsters. His inspiration for all neonatologists. His publications are many, and notable is for 2026. He was Active Pediatrician Award 2024. Welcome you, sir. Over to you.
Thank you, sir, for the nice introduction. So at the outset, I thank the delegates who have turned up so early in the morning to listen all our talks. And I thank the KONGU PEDICON organizing team for giving me this opportunity. So when I got a mail from the KONGU PEDICON team that I have to talk about how to approach a feeding difficulty in a newborn, I was really perplexed because it was such a vast topic. Feeding difficulty means it ranges from sucking difficulty, swallowing difficulty, or coordinating between the sucking, swallowing, and breathing. So we have, its problems are heterogeneous. Same way the newborn, the term, it's also heterogeneous. It may be a preterm newborn, or it may be a baby who stayed in the NICU and was sick and is now trying to feed directly from the mother, or it may be a normal newborn who is facing difficulty in feeding
Timer.
In the postnatal ward. Or
Timer, sir. Timer on பண்ணிருக்கேன்.
Or it may be a normal newborn baby who is having a difficulty in feeding in the postnatal ward, or who turns up to our OP during the follow-up with the complaints of feeding difficulty. But the team, the organizing team gave me a hint that they gave one one-liner, just like the cine movies, the directors give a one-liner. So they gave me a one-liner that day 4 and still not feeding well. So I thought, let me define the boundaries within which I have to do my presentation. So I started to build up the story based upon that. Day 4 and still not feeding well. So let us assume that this baby of a primary mother who was delivered by normal vaginal delivery. So both the things are very important, because we know that the primary mothers and the mothers who are delivered by a cesarean section, they are likely to have some feeding difficulties, even if the baby is normal. And the next, the baby is it's a term baby, appropriately grown for the gestation age, and it's a singleton baby. And we know that the preterm baby, even the late preterm baby, or a small for gestation age baby, or twin babies, they are likely to have feeding difficulties. And in this is an exclusively breastfed baby. Starting right from birth, the baby is on breastfeeds. And we know that any baby who has received any feed other than breastfeeds, especially what we call it as a pre-lactal feeds, they are likely to have a difficulty in feeding. And this baby was discharged on day 2. Most of us are following the early discharge principle, where we discharge a normal delivery baby by day 2. And as per the AAP recommendation, we ask them to come for a follow-up after 48 hours to make sure that everything is going on well. So now we are having a baby born to primary mother, normal delivery, and then a term singleton baby who was breastfed, discharged on day 2 and is turning up for follow-up on day 4. Then I was pondering why the organizing committee has given me a point as on day 4, why not day 14 or day 30? So then I thought that this may be important, because we know that the lactogenesis stage 2, usually it starts by 3rd or 4th day. That means the mother who initially is secreting colostrum, there are some changes that happens in the breast epithelial function. And so now the milk turns into a transitional milk, and this finally becomes a mature milk by day 10 to day 14. So when this transitional milk starts appearing, the milk volume it increases. There will be an edema in the drainage system of the breast. So she may have some breast engorgement. And as the milk volume increases, as the baby takes more and more of milk, usually we see these babies will start to pass a transitional stools. The baby was initially passing meconium, will now start passing transitional stools, which is usually greenish or yellowish, and it will be of more watery, and it will be more frequent. And many times this is the time when the babies are likely to have reached the nadir of their weight loss. Usually by day 3 to day 5, that's the period when the maximum weight loss it happens. So that we will make sure that the maximum weight loss it has not exceeded the stipulated limit. And this is the time when the jaundice is also likely to have reached its peak. So following up this baby on the day 4, it has a lot of implications related to the feeding in a normal baby. And still, if the baby has brought to us with a complaint of not feeding well, the first point I would like to make clear is whether it's a real problem, whether there is a feeding issue in the baby, or if it's a false perception. Many times we see that everything will be going on fine, but still the baby's mother and the attenders, they may be insisting that the feeding is not going well. So first I would like to make myself sure whether it's a real problem or it's just they are perceiving it in a wrong way. So being a pediatrician, I would like to start approaching this situation by examining the baby. First, I would like to see how is the baby. The most important objective sign that makes me sure that the feeding is going on well is the baby's current weight. What's the baby's current weight and how much it's different from the birth weight? The baby's weight loss, it has usually the maximum weight loss that's given in the recommendation is 7% or 8%. So if it's within that limit, I'm very sure that the baby's feeding is going on well. And I will also like to see how much weight the baby has lost after discharge. If there is no significant weight loss after discharge, we always record the discharge weight. And when they come for a review, we see the present weight. If there is not much weight loss, and the actual weight loss is less than 7% or 8%, I'm very sure that the feeding is going on well, then there is something which we have to convince the mother and the attenders that everything is going on well. Another important clue is the number of times the baby is passing urine. Usually by day 4, the baby would have started to pass at least 5 or 6 times urine in 24 hours. And as I told you, the stools, it will be in transitional stools, which will be greenish or yellow, and it will be more watery. And I will also ask how many times the baby is feeding per day. So if the feed frequency is at least 8 times, is more than 8 times in a day, then it means that the feeding is going on well. Many times we see the babies feeding even 10 times or 12 times in a 24 hours period. And the feed duration. This is a very important information. I found it very useful. If a mother says that my baby keeps taking feeds for 30 minutes or 40 minutes, they will be happy that saying that my baby drinks for 30 minutes or 40 minutes, but I am not happy. By day 4, when the milk volume has increased, so many times the baby would have, we expect the baby to finish feeding by 10 minutes or 15 minutes. And then Nelson says that almost 90% of the feed volume which the baby needs, it will be completed by the first 4 to 5 minutes of the feeding session. So if any mother who says that the baby keeps on sucking at the breast for a long time, it means that there is some problem which we have to address. And the interval between the feeds, so this is also very important. And traditionally we are taught that after every feed the baby must sleep for 2 to 3 hours, but many times it won't be like that. So there will be in circadian variation. There will be day-night variation. So the babies, they will sleep for 3 hours, 4 hours, or even 5 hours in a day. And mother will be very much concerned, and they try to wake up the baby and try to make the baby to feed, but the baby won't be active. But in the night time, they will keep on asking for feeds every hour or every half an hour. So when there is such a variation, then it means that the baby is doing well. But if the baby keeps on demanding feeds both day and night, then it means that there is some problem in the feeding. Now I will have a look at the mother. How is the mother? Any mother who seems very worried, who is very emotional, if you start asking about the feeding, if she starts having tears in her eyes, then I have feeling that there is some issue. So there may be a problem in the feeding, or there may be a problem in the mother. And many times, because these babies, they keep on demanding feeds, these mothers, they will look very tired, they will be exhausted, they won't have time to sleep. And the family members also will be pushing her to keep feeding their baby. She won't even have time to go to the restroom freely. She won't even have time to have a good food. So if the mother looks very exhausted, then I am also very much concerned. Then I will look at the mother, whether how is her general health. If any mother who has a fever, or she looks very dehydrated, it means that there is some medical problem going on. It may be related to keep on feeding the baby day and night, or there may be some medical issues which keeps the mother not in a good health. Then I will also inquire about the wound health. Either the normal delivery mothers, they have the episiotomy wound, and the cesarean mothers, they have the C-section wound. And the way they come and sit in the OP, that itself will show that how is their wound. There will be some mothers, they will come and sit very uncomfortably. Some mothers even refuse to sit, saying that it's very paining. Okay, so that also gives us a point that there is some these mothers are likely to have some feeding difficulties. And I will inquire about the food and the fluid intake. So there may be some traditional beliefs which prevent them from having particular types of food. Okay, so then I will inquire about the food and fluid. And if it's multi-gravida, second gravida mother, I also inquire about how was the previous breastfeeding experiences. Any mother who had a difficulty in breastfeeding in the, with the previous baby, they are more likely to have a same problem this time. I will inquire about the past breastfeeding experience. Why all these things is important is, I think you know about this oxytocin or the milk ejection reflex. So this reflex when the baby latches on the nipple, the signals goes to the brain and the posterior pituitary, it secretes oxytocin, which which acts upon the myoepithelial cells in the breast and pushes the milk from the alveoli into the lactiferous duct and out into the baby's mouth. So this oxytocin reflex, otherwise called as a milk ejection reflex, is very, very sensitive to the emotional stimuli. Only if the mother is very comfortable, very happy, or only then this reflex will work properly. If you see, if there is any worry, if the mother is very much worried, if she has a pain, if she is very much stressed, definitely even if the mother has enough milk, she won't be able to transfer the milk to the baby. Okay, so so I will make sure that the mother is very comfortable whenever she goes and sit for feeding. Next, I will inquire about the mother's breast condition. If any mother on day 4 says that she has a breast engorgement, actually I won't be much worried, because usually there will be some amount of breast engorgement, but it should not be so severe that it interferes with the latching. So if she says that she is feeling that the breast is full, and if she puts the baby on one breast, then there is a dripping of milk from the other breast, I know that she has a good amount of secretion. And I will also make sure that whether she has some discomfort in the breast or in the nipple in the form of any pain or tender areas in the breast, which shows that there is some inadequate drainage which is making her to have a pain or tenderness, or there may be evolving mastitis, or the engorgement, it may be so severe that she is feeling the pain, or there may be a poor latching which leads to a soreness or the crackness in the nipple, which is making the breastfeeding very painful. So I have seen mothers where the attendant says that whenever she goes and sit for feeding, when she has a cracked or a sore nipple, she goes pale. She becomes very afraid to feed the baby. So that makes that she is really having a real problem. And I will also inquire whether she has any flat or inverted nipple. Being a male physician, many times I am not in a position to examine the breast, but I have the habit of having some pictures in my system, in my computer system. And if mother is not able to understand some of this, I used to show her a picture and see do we have a similar condition like that. Okay, so that's very helpful to elicit the details from these mothers. Next, I will look at how the baby and the mother interacts. So that means I will ask about the positioning and latching. For this also, I used to show some videos or show some pictures and to make sure whether the positioning and latching is going on well, and whether she feels empty after at the end of the feed. This shows that the baby is taking milk well, and the baby is also receiving the hind milk. And I will also inquire whether she offers only one breast or whether she offers both the breasts, which means that both the breasts are getting adequate stimuli during each feeding session. And I will also inquire whether she offers always one side breast first, or she offers or she alternates between the breast between the sides whenever she starts the feeding, so that both the breasts get enough amount of stimulation so that the secretions will build up. And as I told you, many babies, they are the night feeders. So they will be demanding feeds more in the night time, and they will be having a good sleep in the daytime. But our mothers, they will feed the baby in the night time, and in the daytime they will do all the household chores, and they will feel very much exhausted and sleepy in the night time. So I will make sure that she gets enough rest in the daytime. So why all these things are important is this prolactin reflex is an hormone which is secreted by the anterior pituitary, and again the release is stimulated by the baby latching on the nipple. And this prolactin secretion is important for increasing the secretion from the breast alveoli. And this reflex will work well only when the baby is latching well, sucking well at the breast, and the breast gets completely emptied at the end of each feeding session. And this reflex, this prolactin secretion will be maximum in the night time, so that the night feeds is in synchrony with the natural mechanism of increased breast milk secretion. And how long the baby feeds, I think I told already about that. And how is the family support? So how is there any female caretaker, and how cooperative is the husband? Is there any, and how is their attitude towards the mother, whether they're accusing the mother for feeding difficulty or very supportive to the mother, and how is their attitude to the breastfeeding? So many times everything will be going on well, but the attenders will say that she's not having enough milk. They pass some negative comments of the breastfeeding, which demotivates the mother. And I specifically ask, are you giving any other feed? So it may be any other feed, but I ask them specifically, so sometimes they accept it. So this open statement, it makes sure that they are already started using alternate feeds for handling this breast issue, which indicates that it's really a serious problem where we have to act immediately. So based on this assessment, I plan my action. If the baby is okay, mother is okay, the interaction is okay, and the family support is okay, and still they complain that they are having some feeding problem, I just reassure them. But if the family support alone is a problem, that's just I do a counseling that everything is going on well, you have to support the mother like that, I do the counseling. And if the interaction is not okay, that means the position, latching, or the emptying of the breast is not okay, I do the counseling and I provide the lactational support. And if the mother is also not okay, that means she is very much depressed, she is very exhausted, then I do the lactational support along with the psychological support. So it may be just a counseling, talking to her about her worries, or it may, sometimes it may need a professional psychological help. And if the baby is not okay, then I am really worried, then I plan for evaluating the baby. So the supporting for the lactation is, so how many minutes I have? Okay, fine. So the supporting for the lactation is mainly first imparting the knowledge. We have to tell them about the natural physiology of breastfeeding, that the nighttime feeds are more common, emptying the breast is more important, giving the hind milk is more important. So I used to tell her, I used to impart the knowledge, that's a basic, both for the family and also for the mother. And I observe the breastfeeding. Many times I may not be doing it. I have some nurses with me who used to observe the breastfeeding. And if there is any problem, we used to demonstrate. We used to demonstrate it using videos. We use the mannequins, and then we used to ask the mother to feed. And if there is any problem, we used to address it. And then I used to advise about the adequate diet, taking self-care, having enough sleep, and addressing any medical problem like wound infection is there, then I ask them to go back to the OG and have a consultation. And the most important is encouraging and reassurance. Of these 5 interventions, many times I may not be in a position to do observing a breastfeeding and demonstrating or teaching a skill. One is the lack of time, and another is the being a male gender, the many mothers, they don't feel comfortable to have it with me. So then I get the support from the nurses who are with me. But many times I am able to handle these issues just by imparting the knowledge and then encouraging and reassuring words and advising the mother about the proper diet and the self-care. So when the baby is sick, when the baby is not okay, then I look how well the baby is demanding for the feeds. If the baby is vigorous and demanding for feeds, keep on crying for feeds, even in the consultation room, you will see that the baby will keep on crying. If you keep the baby's finger in his mouth, it keep on sucking very well. If you take the finger out, it will keep on crying. That shows the baby needs more feed volume. So in this case, I will see how is the weight loss. If the weight loss is less than 12%, though the guidelines say that 7 to 8% weight loss is acceptable, many times we see babies having weight loss up to 10%. Even and in literature says that 5% of normal delivery babies and 10% of cesarean delivery babies, they may have weight loss even up to 12%. If the weight loss is less than 12%, I'm not that much worried. So, and then if the baby is sucking well and there is no oral or palatal problems like any cleft palate or such thing is there, if everything is fine, then I advise the mother to have a lactational support. I encourage them to express and feed the milk. It may be hand expression or it may be manual pump or electrical pump, depending upon their financial status and the need. And I encourage them to go for a hind milk feeding. Make sure that with each feeding, the baby receives the hind milk so that the weight gain will be adequate. And I ask them to come for a follow-up in the next 2 days. That's very, very important, okay? And if the baby's demand is not good, that means the baby is very sleepy, or if the baby is poor suck, the baby may have some coexisting problems. So most commonly, such problems are common with late preterm babies or with the infant of diabetic mother. In these cases, again, I encourage them to breastfeed the baby and go for the expressed breast milk. Or the baby may be having sepsis, or there may be some neuromuscular problem, or there can be an endocrine problem like hypothyroidism. In this case, we have to move with the appropriate evaluation. If the baby is very tired, weak, and has a wrinkled skin, it indicates that the baby is dehydrated. In this, this is the protocol I follow in my unit. If the weight loss is more than 15% from the birth weight, I admit the baby, investigate for hypernatremia, acute kidney injury and all, and then I start treating this baby. The weight loss is between 10 to 12%. I already told you we manage such babies with the lactational support and with the expressed breast milk. But if the weight loss is between 12 to 15%, it depends upon the need, depends upon the baby situation, how good is the family, how good will be their turn-up or follow-up, all those things. Based upon that, either I manage it as a OP or I admit and treat these babies. But please remember that these babies are not only dehydrated, they are also hungry and malnourished. So, so these babies, there is no point in just giving an IV fluid. We have to give more. We have to start feeding these babies. So what are the challenges? One is the gender. So if you are a male physician, then definitely you must need some assistant who will be helping you in observing the breastfeeding and teaching the techniques. It takes time to counsel. Definitely it needs at least spending some 5 or 10 minutes extra time to counsel such mothers, and it takes more time to observe the breastfeeding. So when you want to observe breastfeeding, you want the baby to be awake and to be hungry. So you have to wait and you have to wait with the patients and see the breastfeeding when the baby is awake and active. And it takes more and more time to teach and support the breastfeeding technique. When I send a counselor to handle such issues, they spend at least 1 hour to 1.5 hours for observing and teaching the techniques. It needs more such amount of time. So having a person dedicated to do this job is very important. We can't have a lactation counselor always. So we can train any female attender available in our OP or in our hospital, maybe A&M or nurse. So we can train them and we can supervise their practice, and we have to get adequate support from the hospital administrators. So that's how I handle the baby who is having a feeding difficulty. The main thing is if the baby is not doing well and the mother is unhappy, then definitely there is a feeding issue which needs to be addressed. So such babies needs an evaluation. The mother needs needs a proper guidance. We have to observe how well the interaction between the mother and baby is going on, and we have to give a proper support to them. So thanks a lot for your patient listening. Thank you. Thank you so much.
Thank you, Ramesh. You touched the heart of the mother and heart of our listeners also. Thank you very much.
Thank you, sir.
The questionnaires will be in the later part of the day, as there is want of time. Here we end the first session. We'll hand over the mic to Dr. Sugandhi for the next session.
Good morning, everyone. It's indeed a great pleasure for me to introduce our next chairperson, Dr. Sugandhi ma'am. I am a proud student of her. She is a very good academician with vast experience in the field of pediatrics. She has been UG and PG teacher for more than 20 years. She is at present visiting professor of pediatrics, PhD IMR. Her areas of expertise are pediatric critical care. She is a diabetes educator. She is a speaker in NAPM and a faculty in PALS, PMC, various conferences and workshops. She has done several publications in reputed journals. Now I hand over the stage to you, ma'am. Thank you.
Good morning, all. I call upon Dr. Balaji to start his first session about the dengue, scrub and lepto tropical traps in pediatric practice. Dr. Balaji is a bright young pediatrician. Young Dana Balaji? Okay. From Dharmapuri. He is Associate Professor of Pediatrics in Dharmapuri Medical College. And he is very much has expertise in pediatric emergencies, infectious, tropical infections. And he has a lot of course, the slide speaks all his achievements. So I'll be brief. So he has got a lot of publications in various national and international journals, and he's authored lots of important textbooks, and of course his awards are numerous. Now over to Balaji for his topic.
Thank you very much, madam. Thank you. Good morning all. First of all, I thank the organizing committee of KONGU PEDICON and chairperson for this giving me this nice opportunity. So my topic for the next 20 minutes is the common problem, tropical traps in pediatric practice. You all know that tropical fevers are a very common problem in day-to-day practice, but because of close resemblance to other common diseases like pneumonia and sepsis and overlapping clinical presentation, many times this disease will confuse the picture and difficult early diagnosis. So many a time the child present with complications where mortality and morbidity is quite high. So we need some systematic approach. So you all know that during every seasonal periods, either dengue or scrub or flu will cause kill more people and cause more anxiety, not only patients, also to our treating the doctors. So in day-to-day practice, for managing tropical fevers or either diagnosis or management, we have some difficult scenarios. It means some traps. So we will see some interesting scenarios and solutions for these traps or difficult scenarios. We'll come to the first case. Here 8-year-old female child presented with fever, cough and cold, headache and myalgia for 1 week. Child was breathless for 2 days. Obviously, X-ray looks some pneumonia-like picture. Child was treated as pneumonia with oxygen, antibiotics, zone and fluids. No improvement. Antibiotic escalated, but there is no improvement. Child is worsening, so saturation is falling. Repeat X-ray suggestive of ERDS-like picture. So what's the diagnosis? Is it rapidly progressive pneumonia or sepsis or something else? But see that nowadays, tropical fevers many times present with respiratory complications like either ERDS or pleural effusion in dengue and scrub, etc. So whenever the child comes with fever with respiratory symptoms and breathlessness, it is always look for any seasonal outbreaks, travel history, any associated features like shock, ascites, hepatosplenomegaly, lymphadenopathy, eschar in the hidden areas, anemia and thrombosis depending on CBC will give clue that we are just not dealing with pneumonia, it may be a tropical fever. So whatever this, when the child presents hypoxia and shock, the correction of hypoxia and shock is the main priority. So early Jackson entries which provide CPAP, HFNC or early NAV is very much helpful for respiratory distress, and finally try to establish the extra diagnosis earlier to treat. Here the adolescent patient came with fever for more than 1 week with the ERDS-like picture. Obviously nowadays it is very common, it is a scrub where managed with NIV. And here another child have fever, cough and cold, breathlessness and finally found to be having significant fluid effusion, diagnosis dengue, managed with HFNC. So in respiratory problem, we have to think tropical fevers also nowadays. Here again second case, here 10-year-old child, fever, vomiting, abdomen pain, jaundice. So initial picture looks like viral hepatitis, managed like that. But baby's child is having continuous fever and finally shock, breathless and became lethargic, referred as hepatic encephalopathy. Whenever a child present with jaundice, first we have to think that whether it's a hepatotropic disease or non-hepatotropic viral disease. It means on doing LFT, if it is SGPT is elevated, it's almost favors hepatotropic virus like hepatitis A, B, whereas SGOD is more elevated, it may favors tropical fevers, lepto, scrub, malaria, dengue, all will cause liver involvement. So please always look for persistent fever, thorough clinical examination, other organ involvement and urinary findings, CPK and CRP will give clue whether we deal with tropical fever or not that. See, in leptospirosis, the child will present with fever with chills, severe myalgia, muscle tenderness, conjunctival suffusion, and albuminuria and hematuria will be seen in urinary finding. Elevated CPK may give clue. Finally, can be confirmed by microscopic agglutination test or IG Melissa. Whatever the etiology, supportive care for hepatic involvement. Mainly watch for urine output, seizures, encephalopathy, look for bleeding and secondary infection, and vitamin K and laxatives and NSL system infusion. If there is bleeding, FFP or cryoprecipitate may be helpful, but however you have to find the cause and treat it. So it is another common scenario. Here 5-year-old child brought with fever for more than 2 weeks. Child was dull for 5 days, vomiting for 3 days. Child initially treated with Oflax, ceftriaxone, amikacin, not improved. But child was given oral doxycycline for 1 day in the first week. But child vomits out, parents discontinued the drug. As child is having persistent fever, went to another hospital, started meropenem. But there child developed seizures. So as child was sick, referred here. On arrival, child is having sinus infection like picture, febrile status epilepticus, unmaintainable airway, respiratory distress with shock. Child was managed with JR with respiratory support, shock was corrected, seizures controlled. After stabilizing child and thorough clinical examination, there was generalized edema, mild ascites and hepatosplenomegaly. An initial investigation done in previous hospital, MP, dengue, type E, scrub, everything was negative. So after stabilize the child, as seen as infection like picture, zone vanco acyclovir was added. Repeat investigation showed thrombocytopenia with anemia. CRP and procal were positive, elevated liver enzymes. In spite of all the drugs, child is having persistent fever. There is sudden loss of vision for the child, and opthal suggested papillitis and advised steroids. We want to rule out TB and found to be negative. What have to be done? So see, in this juncture, repeat meticulous examination of the child showed that small eschar in the back of the scalp, which give clue that we are dealing with this scrub typhus. Child was treated with IV doxycycline and child was saved. So child, whenever the child presents with persistent fever, hepatosplenomegaly, generalized edema, systemic involvement, anemia with hepatosplenomegaly, capillary leak, please consider scrub. So atypical presentation like CNS, opthal manifestation may be seen, but in scrub, the investigation we are doing serological test, so please better interpret after 5 to 7 days. Here, the cord test was interpreted on 3rd day, and oral doxycycline was not tolerated, so the diagnosis was misleaded. In severe cases, IV doxycycline is useful. It is a newborn child, a 14-day baby, brought with fever and refusal of feed. Birth history was normal. So baby admitted in medical college hospital, treated as late onset sepsis with the fluids and antibiotics and oxygen. But child worsening, persistent fever, so child was referred. So showed again thrombocytopenia, elevated liver enzymes, and CRP PCT was positive. All cultures were negative. As thrombocytopenia with thought of fungal also negative. Ultrasound abdomen showed hepatosplenomegaly with free fluid. So in spite of the drugs, child is have persistent fever with even antibiotics and antifungal. So as thrombocytopenia, MP, typhoids, dengue, everything done, everything was negative. As though it's a newborn child, because of thrombocytopenia, scrub was done, found to be positive, child was treated with the doxy and child improved. In scrub, the eschar is a painless, usually is found in the hidden areas like groins, perineal region, axilla, behind the ear and neck. So we should look for in the hidden areas, then only we can find it. Once you find the eschar, it's a definite diagnosis of eschar, scrub typhus, you can treat it with the doxy, the outcome is very good. So it is present in any age, either from newborn to elderly. A majority of them present with the shock or ARDS. Either rapid cord test or ELISA, it should be interpreted after 5 to 7 days. After doxy, fever is come down, it's a diagnosis of scrub, but when you give oral doxy, please see for the complaints. If persistent fever after doxy, look for mixed infection in this scenario. In severe cases, IV doxy or IV acetro is very much helpful, but should be given as infusion because rapid infusion causes prolonged QT syndrome and sudden death in case of azithromycin. So many times, whenever the child presents with thrombocytopenia, everybody thinks that's a dengue, but nowadays all tropical fevers can cause thrombocytopenia. We should know how to differentiate both. In scrub, there is hepatosplenomegaly. Dengue, they have massive hepatomegaly. Abdominal lymphadenopathy and mild ascites, mild fluid elevation may be seen in scrub typhus, whereas more fluid leak seen in dengue. CRP and WBC may elevate in scrub typhus, and CRP normal, leukopenia seen in dengue. In shock, hematocrit may be normal in scrub. During shock, elevated hematocrit may be seen in dengue. In scrub typhus, there is wide pulse pressure shock, means BP is 120, 0, 110 and 10 like this. In dengue, it's a narrow pulse pressure shock. We move on to the next common scenario. Your 5-year-old child have fever for 2 days during seasonal periods with myalgia. Initial investigation, just a normal WBC with platelet. The doctor told the parents to bring the child if any complaints. Child was lethargic for the next 2 days. On day 5, child brought with hypotensive shock with a significant bleeding manifestation. Doctor asked the parents, why you not come earlier? The attendants replied that there was no fever for the child, so they felt the child was alright. What is the miss here? What is the problem here? See, coming to dengue warning signs, in spite of all other warning signs, lethargy and abdominal pain is more important. Lethargy is commonly missed warning sign in dengue. It means after fever, 3rd day, 4th day, when the child is dull, lethargic, sleepy, not as usual, not playful, it means that the child is lethargic, there is ongoing shock is there. If lethargy is missed, many times the child brought with complication where mortality is quite high. So even though in your busy period, ask the parents where the child is lethargic, means dull, not as usual, please give importance. If this triage question is positive, feeling of peripheral pulse is the cornerstone to diagnose the shock and pick up the dengue earlier. Because in dengue, one advantage, you can diagnose the NS1 antigen initially, so you cannot miss earlier and I can identify earlier. And on interpreting CBC, not only platelet, WBC and hematocrit is also helpful in dengue management. Leukopenia is the earlier finding, and even in recovery, rise in WBC precedes the rise in platelet. Everybody has some doubt whether you have to go for rapid test or ELISA. So whenever there is ELISA is not available, you can go for rapid test, but should be a good validated and good company card test, but should be correlated with the clinical features and CBC and ultrasound findings. When it's not matched, please go for ELISA. It is another scenario. It is also dengue. Child was diagnosed dengue. He was admitted, treated fluids. After 48 hours, child went for hypotensive shock in spite of the fluids. Anxious and furious attenders and fight with the doctors. In spite of treatment, child worsened. What happened? What's the problem? In dengue, every child is different. Severity varies in every child. Quality of leak change in every hour during critical phase. So, continuous clinical examination and serial monitoring of the shock, hematocrit and urine output is very much needed. Because in dengue, early recognition of shock is the paramount importance as the outcome of DSS depends on the duration of shock only. It means when the shock is identified and the pulse burst gets narrow, there is excellent prognosis. If the child brought with cold extremities, prognosis is bad. But BP is low, prolonged shock, obviously there is a grave prognosis. Then how will you diagnose shock? Please look for dorsalis pedis and posterior tibial and capillary refill time and pale peripheries and cool peripheries. So this the thing will give clue that the child is having shock, but see that only trained humans can identify. No machine will help you to identify shock in day-to-day practice. So whenever the child present with actually in busy practice, every child the symptoms may vary. So on admission itself, you should categorize which child is mild problem, moderate problem and severe problem, because you cannot go and look every hour for all the case. You have to train your junior doctors and staff nurses to mark the posterior tibial and dorsalis pedis and ask them to look for pulse every hour along with BP, urine output, whether increase of respiratory rate, what is the abdomen girth. If it is small baby, weight every day or twice a day will help whether the child is worsening or stable. And also you can train the children's mother too. You ask the mother to note down the urine output like this in this paper, they will be more sensitive than the staff nurse because the patient is their own child, they won't miss it. With this record, you can calculate the urine output because continuous monitoring and identification of shock earlier and correction of shock is the cornerstone in the management of dengue. Then why you can avoid the complications. Here the another scenario, it is also a dengue. Here a 3 years old child, fever for 4 days, vomiting 2 days, abdomen pain 1 day, leukopenia, thrombocytopenia. Child was in shock, treated with NS, shock not corrected. Again second NS given, shock not corrected, third bolus given. So fluid 10 ml per kg for going on. In spite of all this, after 6 hours, child again went for shock, hematocrit is rising, respiratory distress, child's abdomen is distended. So attenders are more anxious, so child is worsening after treatment. Child was treated with as per protocol. What could have been done? What's the problem here? See, as already mentioned, every child is different, every leakage in every child is different. So whenever there is severe leakage and frequent leakage, this child need more fluids. So in dengue, what are the fluids you are giving? Everything is leaked and collected in the third space, which will cause more problem. So whenever there is refractory to crystallite, please use colloids that will stay in the vascular compartment some more time, like hydroxyethyl starch, dextran or polygylene. And albumin also very much helpful whenever shock is not corrected with crystallites. Though it is expensive albumin, it is very much useful and decrease the need of more and more crystallites. One thing should be given over 4 to 6 hour infusion, should not be given as a rapid rush. And also whenever you manage the dengue, interpretation of the hematocrit is very much important. Obtain the baseline hematocrit, it will correlate the hematocrit with clinical status. If the child come with shock, hematocrit is raised like 40, you are giving NS bolus. After NS bolus, shock is corrected, hematocrit is coming down, titrate the fluid and reduce the fluid. But in spite of the fluid, the child is having shock, hematocrit is still rising, means there is more leaky. Then you can go for colloid bolus. But after treating with fluids, child is having persistent shock and there is rapid drastic fall of hematocrit, means there is a underlying bleed is there, either GET bleed or something is there. Here you have to go for the blood or pack cell transfusion. So that's why hematocrit will help to manage in dengue. It is another scenario. Here small child, 1 year child, dengue was positive, brought with shock, treated with NS. After 8 hours, child developed significant respiratory distress because what are the fluids you are given, it is accumulated in the pleural cavity and abdominal cavity. Attenders fighting that, you only worsen the child. So what could be done here? See that fluid correction of progressive recurrent ongoing shock is one of the important cause for respiratory distress in dengue. And another thing, whenever it is given as unmonitored or no proper rate, like you are just giving IV fluids inside, just IV set, it will overload the patient. So whenever you treat the child, please use syringe pump, infusion pump or fluid regulator, give the proper rate. That will save the patient and saves yourself also. because whenever the fluid is collected, it will worsen the respiratory distress. So whenever the child presents with hypotensive shock or severe shock or ongoing shock, there are two things you should done. One thing, you should anticipate respiratory distress that should be treated earlier with either CPAP devices like Jackson circuit or HFNC or NIV. And at the same time, you should counsel the parents. This child may develop respiratory distress after 8 hours, may need respiratory support. This child may go for bleeding manifestation. This child may go for complication. You should tell initially, that will save you, not only the baby. So here, in spite of the lungs are very bad, child is managed with Jackson's. Here the small child managed with HFNC and the dengue with respiratory distress. Many times, though the child is very bad, we are not intubating, we are managing with NIV. So many children are managed with NIV and avoided intubation to manage the respiratory distress in dengue. It is the 9th scenario. It is a 6-year-old male child having fever for 5 days, vomiting for 2 days, lethargy for 2 days. Again, child was positive for dengue. Why so many dengue? So in dengue, almost fever, there is rainy season started, cases have started coming. I hope in tropical fevers, dengue is the one causing more problem, not only to child, to the practitioners. So that's why I taken some more examples. Here child admitted, present with hypotensive shock on admission itself. Child was treated with the NS. As we suggested earlier, it is ongoing shock, we shifted to the colloid. We are giving colloid first bolus, second bolus and third bolus as per the protocol. But in spite of colloid, after 6 hours, there is still hypotensive shock. Child developed significant respiratory distress and 2 episodes of hematemesis. So you only told, please give colloid. Now the shock is not correct. What is the problem here? What is the solution? What is the problem? See, it is a case of fluid refractory shock. So in spite of fluid, the shock is persisting. Whenever fluid refractory shock, please look for any bleeding and look for myocardial contractility, coexisting sepsis, any hypoglycemia, hypocalcemia or uncorrected acidosis, raised intra-abdominal pressure, and if it is peritoneus elevated, it may be HLH. If it is CRPS more elevated, it may be a cytokine storm. So you have to find that what is the reason, and you start manage the hypotensive shock. Whenever it shows that it is severe plasma leakage, needs more fluids, either colloids or albumin, and anticipate respiratory distress, treat with earlier GR NIV. And whenever giving ongoing shock fluids, please bedside ultrasound is a simple tool. Everybody can train on it and look for the either IVC contractility and collapsibility and dimension, whether you have to give more fluids or not. And also look for the myocardial contractility. If this myocardial contractility is poor, if you are still giving more and more fluids, it will almost lead to the pulmonary edema where the child is worsening. So it will guide us, shall we give fluids or not. And also, it is very simple technique, so anybody can learn it. You can just put in the almost left side below the nipple. You can look for just cardiac contraction. It is very much whether its contraction is good or bad.
Balaji, 2 more minutes.
Yes, madam. And also, fluid elevation also can be picked up. Once fluid refractory shock, you have to identify the cause and treat. Provide early respiratory support. Inotropes are needed in this situation because restoring the blood pressure is critical for survival. So that again this problem child had bleeding manifestation. So whenever the child was presented with hypotensive shock or prolonged shock, so those child may develop bleeding. It means that elevated APT for more than 1 minute and ecchymosis, persistent vein infection site bleeding, INR more 3. It is if these factors are present, the child may develop bleed. So in this condition, if there is significant GI bleed, you have to give the prespaxil or press whole blood. But no prophylactic FFP is needed. But when the child is unstable, an altered coagulation profile, ecchymosis, persistent vein infection site bleed is there, single unit of FFP with vitamin K is helpful. And if there is elevated liver enzyme is more than 1000, NS16 infusion is also helpful. This is the last scenario. 18-year-old male came with fever for 7 days, chills and rigors, lethargy. Investigation showed anemia, thrombocytopenia, hypoglycemia. Dengue was positive. Dengue as per protocol treated, but patient is on persistent fever and lethargy. As anemia and thrombocytopenia, we done scrub, it is also negative. Patient developed seizures and intubated. What is the problem here? How to further workup? But when we review the history carefully, we found that the patient came from the Odisha with fever. What is the importance in Odisha? In Odisha is the endemic for falciparum malaria. So malaria was confirmed by rapid test, treated with artesunate, the patient is improved. So tropical fever, mixed infections are quite common. In any infection, after standard recommended treatment, the patient is not improving, rule out mixed infection. Persistent fever after specific therapy or worsening clinical status after standard treatment in suspected case of dengue. Persistent fever after dioxin scrub type suggestive of mixed infection. So coming to final slide. So many times children present as acute undifferentiated febrile illness or various complications, Knowledge of areas with recent outbreaks is very much helpful. High index of suspicion, complete history taking and perfect clinical examination is very much mandatory. Early identification complications and frequent monitoring, early intensive care and supportive care for hemodynamic derangement is very much needed. Drugs are very few in tropical fevers like zone, acetro, aceclavir, artesunate and oseltamivir. Just 5 drugs for tropical fevers. We don't need Vanco, Miro or Cefoperazone, ceftazidime like that. In dengue, not to miss lethargy and abdominal pain. Earlier diagnosis of shock and fluid management. When more fluid leak, please give colloids. Whenever the child presents with recurrent fluid leak, recurrent shock, anticipate fluid refractory shock, respiratory distress and built-in diathesis and counsel them properly and treat early or life-saving. Try to arrive at a specific diagnosis. This will reduce the childhood morbidity, mortality, expensive PO workup and unnecessary use of excessive drugs, and also saves us in today's scenario. I thank one and all for this nice opportunity and kind attention. Thank you very much.
Thanks, Dr. Balaji, for this excellent presentation. You showed a lot of your own clinical scenarios from Dharmapuri, starting from a 14-day-old newborn up to 18 years old. So kindly stay here for the questions. And
Thank you much, madam.
Yeah, one instructions to the audience. If you have any questions, please write in a sheet of paper and pass on to me. We'll go to the next session. I call upon Dr. Murugesa Lakshmanan for the second session. Recurrent infections in a child, is it a primary immunodeficiency? Dr. Murugesa Lakshmanan is Associate Professor of Pediatrics from Madurai Medical College. And he's an active member of IAP, and he's very interested in teaching various sessions and workshops in conferences. Over to you, Doctor.
Thank you, Madam. Good morning, one and all. At the outset, I would like to thank the organizers of KONGU PEDICON for giving this opportunity and also for the wonderful hospitality. So, approach to childhood recurrent infections, is it PID? That is my topic for today, and the next 20 minutes we'll be seeing what it is. And the caption below, there's an expanding universe of inborn errors of immunity. What it is, we'll see in the next few slides. What is the importance? So, objectives of my talk will be like, what are the newer concepts in PIDs, that are primary immune deficiencies, and how we classify all these diseases, and some case-based discussion for some better understanding. So it is a functional abnormality of one or more components of the immune system. It may affect the innate immunity or the adaptive immunity, or it can be a problem of the both. And some cases are a real immunological emergency, where you need to treat immediately with a bone marrow transplant, like the SCID, severe commune immunodeficiency. You don't have much time. You have to intervene immediately. It's an immunological emergency. And currently there are more than 550 disorders classified under PID. Though as a group, PID is not very rare. They are pretty much common. But individual diseases are pretty rare. So it is essential that we have the right suspicion to diagnose early. And currently, there is paucity of data from India, but some things are improving in the last 10 years. Some 15 years back, there was no data, there was nothing to diagnose in our place. But in the last 10 years, the rapid developments are taken in India, and more and more data and more papers are coming from India. So, initial diagnosis, most of the time, is frequently delayed because of low index of suspicion by the initial treating doctor. Like I told, a rare individual disease incidence. And protein manifestations, because most of diseases in children are present with infection, cutaneous lesions, failure to thrive. Any disease presents failure to thrive. So it leads to a lot of confusion and delayed diagnosis. And the immune system, if you see, it actually has 3 actions mainly. It protects against pathogens, it keeps a check on autoimmunity, and it plays a role in cancer surveillance. So any problem in the immune system can result in problems in all these things. So, more and more diseases are diagnosed because of the increased developments in the field of genetics and immunology. More and more conditions are being diagnosed every year, and currently there is, like I told, there are more than 550 disorders, and currently there is a big mismatch between the term primary immune deficiency and conditions, some conditions with primary immune deficiency where immune susceptibility is not the only criteria to diagnose it. So in 2017, the International Union of Immunological Society coined the new term inborn errors of immunity, which gives a broader encompass. So if you see why I told it's a expanding universal inborn aerosol immunity. If you see in this slide, in 2017, almost only 300 conditions were there. But now in 2024, more than 550 diseases have been diagnosed, right, because of the improvements in genetic diagnosis. See, even between 2022 and 24, see the red blocks show the number of new diseases diagnosed in the last 2 years. That itself is a considerable number. More than 50 new conditions have been diagnosed in the last 2 years. So such is the rapid development happening in this field. So this is the broad classification in how these all these 550 conditions fall under either of these 10 categories, like common immunodeficiencies, combined immunodeficiency syndromic features, predominantly antibody deficiencies, and deficiencies of immune dysregulation like HLH, congenital defects of phagocytes, the CGDs, the defects in intrinsic and innate immunity, autoinflammatory diseases, complement deficiencies, bone marrow failure syndromes, and phenocopies of inborn aerosol immunity. So these are the broad headings under which all these conditions are diagnosed. So when I was a student, these were the warning signs of the Jeffrey Models Foundation's 10 warning signs of primary immune deficiency, which mostly deals with the increased susceptibility infections like 4 or more new ear infections, serious sinus infections, pneumonias, failure of an infant to gain weight, all these recurrent skin abscesses, all those things were the main things. But now, like you see, the 10-15 years back, only SCID, chronic granulomatous disease, all those things were things we know. But now, like I told, autoinflammatory conditions, bone marrow failure syndromes, so many new things are being diagnosed and coming under the umbrella of inborn errors of immunity. So, you see, the older one, the left side, recurrent infections, severe infections were the older diagnostic criteria. But now if you see the right hand side, autoimmune cytopenias, lymphoproliferation, cancer predisposition, eczema, endocrinopathies, systemic autoimmunity, and vasculitis. All these things should make you suspect a inborn immunity in a child. So why is it important? We can have many answers. Even common in the COVID epidemic, why some patients develop severe disease, why some patients escaped with a mild disease and some patients died. Even those answers for these can be found in inborn errors of immunity. In patients with X-linked toll-like receptor 7 deficiency had severe COVID-19. Again, 10 to 20% of patients severe COVID-19 had high levels of neutralizing autoantibodies to type 1 interferons. So, explanation of many things can be found in these conditions. So, coming to the case scenarios, case number 1, this is a 4-month female child, second under birth. The child presented with features of lower respiratory tract infection and refusal of feeds. The BCG scar was absent, though it was immunized for age. This was a child with child had proptosis. On day 4 admission, child developed proptosis of the right eye, and the X-ray showed consolidation of right upper lobe and middle lobe infiltrates. So when you done a basic investigation, like a simple investigation like a CBC, if you see, it showed absolute lymphopenia. See, any observed lymphocyte count less than 2,500 in the immediate neonatal period, always suspect lymphopenia. So that is a very good marker for to diagnose SCID, severe combined immunodeficiency. So we had a suspicion of SCID in this child, and we sent investigation for lymphocyte subset analysis to enumerate the T cell and B cells and NK cells. And meanwhile, done a MRI screening showed features of suggested disseminated tuberculosis. In Western countries, actually, what they do is they do a universal screening for SCID, and only when the results are available, they give a BCG vaccine. But in our country, what happens is you give the BCG vaccine at birth. So many of these SCID children present with disseminated tuberculosis even at the time of presentation. It makes it very difficult to treat these children. So the lymphocyte subset analysis showed a decreased T cells with normal B cells and NK cells. The immunoglobulin profile IgG and IgA were decreased. So we made a differential diagnosis of T minus B plus and NK plus SCID. And the child was put on antibiotic prophylaxis for cotrimoxazole for 3 days a week for pneumocystis, acyclovir for viral infections, fluconazole for candida, and palivizumab during RSV season, but it's not available in India, so recommended. And diagnosis confirmed by genetic screening. And we done a bone marrow transplant for this baby, but unfortunately the died post-transplant. So the learning point in this case is a simple complete blood count would give you a clue like to a serious disease like a SCID. So these are two other cases of skid. The left side child is you can see the rash with the hepatosplenomegaly. Child presented LRI and a BCG ulceration, scar ulceration. Again, gives a clue. This child also got observed lymphopenia, but unfortunately, child kept during the COVID period. We couldn't do much, and child died. Next child, if you see, it is again presented palatal perforation due to fungal infection. Palatal and septal perforation due to fungal infection. Again, the child had a low lymphocyte count. It was kid child, but presented late, so couldn't do much. Case number 2, this child, you see, the child was diagnosed at birth with delivered emergency LSCS at 36 weeks because of fetal anemia, and with resuscitated with blood transfusion, and the parvovirus B19 was negative for this baby, and discharged on day 20. After 1 month, again child presented the anemia and severe pancytopenia. The bone marrow showed erythroid hypoplasia and dysmyelopoiesis. The child was put on monthly blood transfusion. In between, the child admitted for pneumonia twice and treated with IV antibiotics. And if you see the serial counts, the child showed pancytopenia. So he had a differential diagnosis of inherited bone marrow failure syndrome, primary HLH, and myelodysplastic syndrome. And again, at 2.5 months, child developed the septic arthritis, required a drainage and arthrotomy. And workup for HLH was negative. But if you see the immunoglobulin profile, it was IgG, IgM, IgA were all decreased. And lymphocyte subset analysis showed decreased B cells. And again, like I told, the bone marrow picture was suggestive of myelodysplastic syndrome. And ultimately, the genetic screening, genetic testing came as MYSOM gene mutation. It was an inherited bone marrow failure syndrome. And child was treated with the hematopoietic stem cell transplant, and child is doing really well. The child got a donor, and the lucky child got with an unrelated donor with 10/10 match, and the child is doing well, really well. You can see the child is grown up now, doing well. So the learning point here is, like I told, cytopenias can also be a present feature of inborn errors of immunity. Initial percentage need not be always recurrent infection. Case number 3, 7 months old, 3rd-degree consanguineous marriage, presented recurrent LRTA and ASOM, starting from 45th day of life. See the consolidation. So this child had recurrent suppurative otitis media with LRI, with needing frequent prolonged antibiotics, presented anemia, leukocytosis, and persistent thrombocytopenia and raised ESR. In this background is suspected immunodeficiency, and subset analysis was normal. Immunoglobulin assay showed some increase in IgE. So immunoglobulins can be increased in chronic granulomatous disease and autoimmune lymphoproliferative syndromes. So we done a genetic testing, clinical exome sequencing, which confirmed a diagnosis of chronic granulomatous disease, and child is currently on antibiotic prophylaxis for itraconazole and cotrimoxazole twice daily. Here we give cotrimoxazole daily. In SCID we give thrice weekly for pneumocystis. Here we give daily for staphylococcal prophylaxis and itraconazole for aspergillus, and child is currently planned for transplant. Case number 4. This is again a 5-month-old male child presented with ulcers over the umbilical region, face, upper chest, perineal, almost the whole body, but there was no pus formation. There was only serous discharge from the ulcers, the low-grade fever, and history of delayed fall of umbilical cord. Like that, with this scenario, we can all tell it is a suspected case of leukocyte adhesion deficiency. See the photo. There's no pus formation there. Everywhere only the ulcer is there, no pus formation, only serosanguineous discharge is there. And it showed neutrophilic leukocytosis. Again, child was started on antibiotic prophylaxis. Flow cytometry showed leukocyte adhesion type 1 defect. DHR test, dihydrorhodamine test was done by flow cytometry, and it came up as leukocyte adhesion deficiency type 1. Again, this child also, bone marrow transplant was done with a sibling, elder sibling. Dietary database, and the unmatched, this child also done with unmatched donor, and child is also doing well. So this is case number 5. This child presented limping gait by about 2 days at the age of 3 years. No injury, no injections in the gluteal region, no fever, only limping gait. This child at the age of 11 months had suppurative lymph axillary adenitis, which did not respond to antibiotics, treated outside or elsewhere, and ultimately empirically started the ATT for 8 months, and the wound healed. The past CBCs were not of much help. A child had received BCG vaccine. Again, we done a MRI because of the limping gait. It showed left psoas abscess, and which did not respond to antibiotics. So under general surgery, the pus was drained, and the CP nut was positive with rifampicin sensitivity, and started on ATT for the 4-drug regimen. After a month, the swelling at the site of discharge, there are residual collection, aspiration was not possible, and the genetic diagnosis came as MSMT, Mendelian susceptibility to mycobacterial disease. And this child is on modified TB regime and planned for stem cell transplant. Case number 6, this child, 6-month-old at the time of presentation, second order birth, consanguineous marriage, for fever and cough for 6 days, abdominal distension. On day 5 admission, the child developed icterus. The child had hepatosplenomegaly with pallor. And looking at reviewing the family history, the elder sibling also died at the age of 6 months with some undiagnosed cause of jaundice, the mother told. So with this picture of pancytopenia, hepatosplenomegaly, mild pleural effusion, we suspected primary HLH in this child with the previous sibling death. He started antibiotics. Workup for HLH was done, and it was suggestive of HLH, elevated triglycerides, fibrinogen, and serum ferritin. Bone marrow, there was no evidence of HLH, but still we strongly doubted because of the lab parameters. And 5 out of 8 diagnostic criteria are positive. We started treatment with HLH protocol, 2004 protocol. At the same time, we done a clinical exome sequencing, and came as type 3 HLH, primary HLH. And this child also referred to higher center for bone marrow transplant. And this child is now around 5 years, I think. Is doing really well. And case number 7, this 2-year-old child with non-consanguineous parents. He was a known case of cholesteatoma with atresia of left ear canal, admitted in the ENT department for mastoid exploration, but they referred to the pediatric department for LRI symptoms, cough for 10 days duration, ear discharge, the inadequate weight gain. The child had history of LRI, recurrent LRI since the age of 6 months. BCG scar was present. The initial X-ray test was normal when the child was referred from ENT department, but the repeat X-ray showed bronchopneumonia. The CT test showed multifocal areas of consolidation. And the investigations, except for elevated total count, it was not much helpful. Pus culture showed pseudomonas from the ear discharge. And reviewing the history, the child had persistent pneumonia, not responding to antibiotics for 4 weeks. Ear discharge for the past 1 year, on and off. Failure to gain weight. We suspected a primary immune deficiency in this child, and immunoglobulin profile was sent. And if you look at the immunoglobulin profile, there was a decrease in IgG, IgM, and IgA. The lymphocyte subset analysis also showed a decreased B cell count, and we thought, because in the background of decreased normal B cell count with the decreased immunoglobulins, we thought it's a common variable immunodeficiency. But common variable immunodeficiency usually present in late adolescents or in adults. So we done a clinical exome sequencing, and it came as a immunodeficiency with centromeric instability, facial anomalies syndrome 1. It presents as hypogammaglobulinemia with facial dysmorphic features, macroglossia, and increased tendency for malignancies. And the child was treated with IVIG, and the child was improved clinically and discharged, and child is currently on immunoglobulin treatment. So carry home message, careful and accurate history is a cornerstone of diagnosis. Early recognition is crucial for these unlucky children, because timely diagnosis and early treatment saves lives in these children. Appropriate management, vigilance for infection, good infection control, and compliance on the part of the patient for the treatment improve their quality of life. Thank you. So if you need any further reading, you can go to the website. There's the Indian Society of Pediatric Immunodeficiency, the ispid.org, their website is there. There you can go and you can get all the details regarding where you can diagnose these some conditions, which are the labs which are approved for sending samples. In fact, National Institute of Immunohematology does these tests, most of the tests for free of charge for government institutions. So we use NIH for diagnosis of these conditions. Thank you.
Thank you, Dr. Lakshmanan. This topic is a tough topic for a common pediatrician, but you try to simplify as much as possible. And the points what I learned is about the newborn screening for SID is really helpful. And the second is how useful the bone marrow transplantation for these PIDs. Only thing, it's very expensive. The audience, if you have any questions, you can ask, or if you have questions for Balaji or Dr. Lakshmanan. Okay, I thank both of them for the wonderful session. Next session, Dr. Arun Kumar. Thank you.
The next session will be chaired by Dr. Arun Kumar, sir. He is presently the coordinator of Medical Education Unit, Secretary, NABH and Curriculum Committee. Sir is the advisor for Benchmark Medical Trust. Sir has several professional achievements. He has received the Honorable Teacher Award 2024, Best Doctor Award for the year 2025, COVID Warrior Award from Karpagam Charity Trust, and he was the chairperson for Ooty Neocon 2023. He was the past Joint Secretary of Coimbatore IAP, and he has organized multiple CME programs. Sir has several national and international publications. Now I hand over the stage to you, sir.
Good morning, one and all. Now, I would like to call a respected speaker, Dr. Dhanlakshmi ma'am, to give a lecture. The speaker needs no introduction. She has multiple publications, 33 publication in index journals and 3 textbook chapters. Please, ma'am.
Yeah, very good morning one and all. I thank the organizing team for giving me this opportunity. So, topic for today's discussion is newer antibiotics. So, what are the indications, efficacy, and how we are going to apply in the clinical case scenario. So, in the next 20 minutes, we will see the need, what is the need for the newer antibiotics, and timeline of antibiotic introduction, and how to classify the beta-lactamases. If you understand the beta-lactamase classification only, then this newer antibiotics where to apply will be better to understand. And what are the newer drugs for gram-negative infections, gram-positive infections, and conclusions. So what is the need for the newer antibiotics? It all starts with the antimicrobial resistance. A recent study published in Lancet, it shows in 2019, you see 1.27 million deaths were due to antimicrobial resistance. And they predict by 2050, 10 million people will die of drug-resistant infections every year. So this is the timeline of antibiotic introduction. If you see the pre-antibiotic era, and in 1929, Fleming first published a paper on penicillin. Then it was given to World War I soldiers. And if you see, once penicillin is introduced, the penicillin resistance developed within 5 years. So whenever a newer antibiotic comes into the clinical practice, the microbes are developing resistance. And the golden era of introduction of newer antibiotics is where 1950 to 1970, you see over 20 new classes of antibiotics were introduced. And up to 1987, so they say this is a major year. After that, no major classes of antibiotics were introduced. So if you see like beta-lactams, cotrimoxazole, they are all new classes of antibiotic. For the past 30 years, there is no new class of antibiotic. Whatever antibiotics we have, they are just modification of the existing class of antibiotic, or the older drugs like colistin, fosfomycin, they are repurposed for now the new clinical introduction. So this is the WHO statement. So they say even though the number of newer antimicrobial agents on pipeline, it is increasing from 80 to 97, there is a pressing need for newer innovative agents, like new class of antibiotics are needed. So we, even though we have newer antibiotics which are just the modification of the existing drug, we need a new class of antibiotics to tackle this antimicrobial resistance. So innovation is badly lacking. Yet when new products are authorized, it is not going to the place where it is really needed. So that is a real problem. So WHO in 2017, they released a list of priority pathogen list based on the need for introduction of newer antibiotic. They categorized into critical priority pathogen, high priority pathogen and medium priority pathogen based on the need for introduction of newer antibiotics. So even though newer antibiotics were introduced from 2017, like example plasmomycin, eravacycline, cefiderocol, and newer BLBLIs like whatever we are using now, ceftazidime avibactam and aztreonam avibactam, ceftalozone tazobactam, meropenem aboribactam, imipenem cilastatin relibactam. So even though these are all approved, fewer like only ceftazidime avibactam, aztreonam avibactam we are able to get. So this is the 2024 update. If you see the critical priority pathogen, carbapenem resistant Acinetobacter comes the priority list, and Enterobacteriaceae, E. coli, Klebsiella, which are ESBL producing and carbapenemase producing, that is carbapenem resistant E. coli, carbapenem resistant Klebsiella. So these are the critical priority pathogen. And high priority pathogen, if you look into Salmonella typhoid, so you will be wondering why it comes into the list, because we are seeing now ESBL producing Salmonella typhoid, ceftriaxone resistant Salmonella typhoid, and Shigella also. So many times in clinical practice also we are seeing ceftriaxone resistant isolates of Shigella, which is a new threat now, and Enterococcus species, which is vancomycin resistant, and Pseudomonas aeruginosa, again carbapenemase producing or carbapenem resistant isolates, and again we have MDR-TB, which is a big threat. It comes under critical priority pathogen. So this slide is very important. If you understand this slide only, the newer antibiotics will be able to understand better. So what is beta lactamases? They are the enzyme which is produced by the gram-negative bacteria, which is responsible for resistance. So this is beta lactamase enzyme. So how you are going to classify? It's a two major classes, that is serine beta lactamase and metallo beta lactamase. There are four classifications: group A, group B, group C, group D. So out of these four classes, only group B comes under metallo beta lactamases. It has active metal in the active site. So that is called, it is metallo beta lactamase. Whenever I mention group B, that is metallo beta lactamases, that is separate group, and all other group are serine beta lactamases, that is class A, class C, class D. So what comes under class A? Whatever we commonly refer to as ESBL producing, carbapenemase enzyme. The common enzyme, one of the common enzyme is KPC. KPC expansion is carbapenemase enzyme, which is produced by Klebsiella pneumoniae, that is called KPC. In India, KPC is not a major problem. In Western countries only KPC is a big problem. That is why if you look into the Western literature, they all talk about KPC producer, KPC producer. But in India, class A is not a major problem. For us, in class A, only ESBL production is a common problem. But on the other hand, if you look into the class B, that is metallo beta lactamases, in India, the main reason for carbapenem resistance is metallo beta lactamases. So what are the enzymes come under class B? It is NDM, that is New Delhi metallo beta lactamases. We often hear the term NDM producers, NDM producers. So NDM, IMP, VIM. So these are class B, that is metallo beta lactamases. So if you come to class C, this is HAM-C producers. This is not a major problem. So they are all hydrolyzed by like till cephalosporins, it will be hydrolyzed, and we will be able to overcome the resistance by carbapenems. And class D is again OXA48 like. Again, this is one of the carbapenem resistant producing organism. So if you take beta lactamases, we are having two classes, serine and metallo beta lactamase. Class B is totally different. Class A, class C, class D. These comes under one group. So this classification you should be thorough. And how we are going to overcome this beta lactamases? By adding a beta lactamase inhibitor. So far we are using in clinical practice amoxicillin clavulanic acid, cefoperazone sulbactam, piperacillin tazobactam. So these are all old generation, that is first generation beta lactamase inhibitors. Now we have second generation beta lactamase inhibitors. If you look into the second generation, what are the drugs we have? Avibactam. So we started using now avibactam. So avibactam, relibactam, zidibactam, nacubactam, And there is one more class, that is boronic acid derivative we call. It is a Weber-Bactam. So these are some of the newer beta-lactamase inhibitors which comes into the market. Okay. So if you look into the newer beta-lactamases, what are the newer beta-lactamases we have? Ceftazidime avibactam is available in the market right now. So if you see any like gram-negative, again it is classified into Enterobacteriaceae, that is E. coli Klebsiella as one group, and non-fermenting gram-negative bacilli, that is Pseudomonas and Acinetobacter as two other group. So why this distinction is very important is, now the main problem is carbapenem resistance. The mechanism of carbapenem resistance in both the groups is extremely different. In Enterobacteriaceae, it is only by enzyme production. You should know what is the enzyme which is causing this carbapenem resistance, and if you tackle that enzyme, you are able to overcome the resistance. But in the other group, in Pseudomonas and Acinetobacter, apart from enzyme production, there are other mechanisms of resistance comes into play, like efflux pump mediator. Whatever the drugs comes into the cell wall or cell membrane, it gets effluxed out. So there are other mechanisms of resistance which is responsible for carbapenem resistance. So that's why knowing not only the enzyme responsible will not help in choosing our right drug. So that's why it's always classified into two classes. So if you look into the newer drug ceftazidime avibactam, it works again class B, class D. Okay, MBLs are not inhibited by this newer beta-lactamase inhibitors. To overcome this class B, we need aztreonam. So that's why always for MBL, we have to have a drug with aztreonam as a base. Okay. So if you look into the Acinetobacter group, so for Pseudomonas, ceftolozane tazobactam, which is a good drug, it is available in the West. Very soon we may get the ceftolozane tazobactam also. So for Pseudomonas, ceftolozane tazobactam, ceftazidime avibactam is going to work. And the cefiderocol is an excellent drug. Actually, it is available in the West. It covers all the mechanism of action, plus it works against Pseudomonas and Acinetobacter also. So between this 2017 to 2023, 13 new antibiotics which is targeting this newer priority pathogens has come into the market. So most of these works against gram-negative organism. So the newer drugs are sulbactam, darlobactam, delfloxacin, meropenem eborbactam, plasmomycin, eravacycline, omadacycline, imipenem, cilastatin, relibactam, lefamulin, proteomanid, this is against TB, and lascufloxacin, cefiderocol, levonadifloxacin, and cortisone. So the carbapenem resistant Acinetobacter is a main problem, and to overcome this, two effective drugs are cefiderocol. So cefiderocol works against all beta-lactamases including MBLs, and clinical and microbiological data see always for Acinetobacter you use a colistin based regimen. So if you compare colistin based regimen with cefiderocol, more or less the same efficacy. And the other drug which is going to come in the market is sulbactam, darlobactam. So it is again non-inferior to colistin. So as per IDSA guidelines, so how to manage this carbapenem resistant infection? So as we know, KPC producers, that is class A beta lactamase producers, and the other class is MBL, that is class B, the other is OXA48, that is class D. So KPC, this is not a major problem in India. So how to identify what is the enzyme mechanism? Suppose in the phenotypic sensitivity, if you find the carbapenem is resistant, then you can do a test called CARBA-R. So if you, it's the same gene expert platform what you are using for TB. So if you send CARBA-R, then they will say whether it is a KPC producer or OXA producer or it is MBL. It helps in choosing the right drug. So if it is a KPC producer, we can use ceftazidime avibactam as a monotherapy. So the alternatives are cefiderocol. Tigecycline is always should not be used as a monotherapy, and it is very bad for bacteremia. It can be used as a combination therapy with other drugs like one or two drugs effective against carbapenem resistant organism. So tigecycline, eravacycline are alternatives. If it is an MBL producer, so to inhibit the MBL, definitely aztreonam is needed. Ideally, those organisms which produces MBL, they co-produce other beta-lactamases also. So we should have a beta-lactamase inhibitor along with aztreonam. Unfortunately, aztreonam avibactam is an ideal drug, but in India, aztreonam avibactam is not available. So right now what we are doing is, we are using ceftazidime avibactam and aztreonam as simultaneous infusion, thinking that inside the body it works like aztreonam avibactam. So that is the rationale you combine these two drugs. And if it is OXA48, again ceftazidime avibactam is an excellent drug. So for class A and class D, ceftazidime avibactam, and for class B it is ceftazidime avibactam plus aztreonam. Inhibits class D also. Unfortunately, it has no activity against class B, that is metallo-beta-lactamases. And what are the indications? It can be used in intra-abdominal infections, urinary tract infections, hospital-acquired pneumonia, bloodstream infection. But it has no activity against anaerobic infections. So that's why if you are planning to use ceftazidime avibactam for an intra-abdominal infections, it is preferable to combine metronidazole also. So it has no activity against MBL, it has activity against class A and class D. So no action against MBL and variable activity. OXA48 it works well, but sometimes something called OXA33 and OXA40 like. So it has variable activity, depends on the sensitivity you have to use it. And against Acinetobacter it has no activity, against anaerobes it has no activity. So the next major drug is aztreonam. So aztreonam, it inhibits the class B enzymes, class B beta-lactamases. So excellent activity against metallo-beta-lactamases. But the problem is those organism produces the class B will co-produce other beta-lactamases also. So you should have a beta-lactamase inhibitor. So that's why we combine aztreonam with avibactam. So this is an excellent drug. If you use aztreonam avibactam, it inhibits against all classes. But it is unfortunately, it is not available. Till it becomes available, we are using ceftazidime avibactam plus aztreonam. Inside the body, we expect it to work as aztreonam avibactam. Currently, aztreonam is available as a single drug and avibactam is now comes as a separate drug. We can use this in 4:1 combination also. So cefiderocol, it is an injectable siderophore cephalosporin with potent activity against all the carbapenem resistant organisms, including non-fermenters, that is Pseudomonas and Acinetobacter also. The unique mechanism of action allows it for a high intracellular penetration of the drug into the periplasmic space, so that it has an increased stability against serine, that is class A, class C, class D, also against class B. So it has potent activity against all the gram-negative organisms, including the CRE and MDR Pseudomonas and Acinetobacter. So the other drug what we are using is tigecycline. So what is tigecycline? It's again glycyl cycline group of antibiotic. It the mechanism of action is by inhibiting the protein synthesis. And the problem with the tigecycline is it has a rapid penetration. So once it is administered, it enters the serosal tissues, it enters the serosal cavity very well, but it doesn't stay in the blood for a long time. So that is why it is inferior for a bloodstream infection. So choose a rapid tissue distribution. So therefore limited concentration in the urine, blood, pulmonary epithelial fluid and serum concentration. So for bacteremia, it should not be used as a monotherapy. So, but it is intrinsically resistant to Pseudomonas. For Pseudomonas infection, tigecycline should not be used. So, current indication is for intra-abdominal infections, skin and soft tissue infections and for community acquired pneumonia. The other drug is minocycline. The main advantage is, again it is a tetracycline derivative. It has a good serum concentration as well as tissue penetration. It It has good activity against Acinetobacter, but again remember it is all the tetracyclines are bacteriostatic. So it has to be combined with the other drugs in case if we are using for bacteremia. The older drugs which are repurposed now is fosfomycin. So fosfomycin was once introduced in early 1940s itself, but because of the resistance pattern, now we started using this. There are two formulations available, IV oral. In pediatrics, oral formulation is no value. Only IV preparation has to be used, and it's effective against gram positive also, gram negative and gram positive, even in fact against MRSA, VRE. So the main advantage is it has a good tissue penetration. So bone, lung, CSF, in fact CSF it has an excellent penetration. So effective in abscesses, it has activity against biofilm production also. But again the same problem is it is resistant to Pseudomonas with variable activity against Acinetobacter species. Colistin, we all know this drug. Again, this is the old drug which is repurposed now. It penetrates most of the tissue, achieves excellent urinary concentration, but poor lung penetration. So the adverse effect we know it is renal toxic and neurotoxic. And the other formulation, polymyxin E, is 2 more minutes. So the polymyxin B can be used. This is the active form of the drug. Colistin has to be converted into the active form of the drug inside the body. So that means colistin is a pro-drug, but polymyxin B is an active drug. The main advantage is less nephrotoxic and less neurotoxic compared to colistin polymyxin B. The one problem with polymyxin B is poor renal concentration. So for UTI, colistin, for other infections, polymyxin B can be used. So why, but we are not using polymyxin or colistin now? Because of the toxicity, that is renal toxicity and neurotoxicity. And the PK/PD parameters, that is pharmacokinetics and pharmacokinetics, are highly unreliable. That is why if you look at the sensitivity, they never report as colistin sensitive. They always report as colistin indeterminate sensitivity. But if you look at the MIC, if it is less than 0.5, it is going to be sensitive. So we are moving away from colistin based regimen. Whenever possible, the newer BLBLA should be used. So this is a new drug which is going to come into the market, that is Zinich. So this is a combination of Zidibactam and Cefepime. It has excellent activity against bloodstream infection, bacterial pneumonias, hospital acquired and ventilator associated intra-abdominal and urinary tract infection. So one more new class which is going to come up is tethered macrocyclic polypeptide. It has excellent activity against Acinetobacter. So there are newer drugs for gram-positive organisms also. Because of lack of time, I'm just going to skip this. But this ceftaroline we are using now. Okay, so the main advantage is 5th generation activity against both gram-positive and gram-negative organism. Remember, it has no activity against Pseudomonas. Take-home messages, MDR organisms on the rise. Appropriate antibiotic use will help in reducing the antimicrobial resistance. Whenever possible, we have to discuss the microbiologist about the mechanism, what is causing the resistance, and a molecular test is available to confirm what is the mode of resistance. Definitive therapy should be targeted and should be a narrow spectrum. Colistin is no longer recommended used in the treatment of CRE. Superior activity with ceftazidime avibactam with or without aztreonam. For class C and class D, only ceftavi. For class B, you have to combine with aztreonam. Aztreonam avibactam, if available, it's better to use. MBL and non-fermenting carbapenem resistant Acinetobacter still remains problematic. New treatment options remain sparse. Access to new agents may be limited due to cost factors, particularly in resource limited settings. As the new agents emerge, these bacteria will continue to evolve in response to selection pressure. So early reports of resistance now to ceftazidime avibactam is now available. Once you use, after 3-4 years, every drug is going to become resistant. That's why rational antibiotic use helps in avoiding the development of resistance. So the interval between discovery of new agent and reports of clinical resistance is disappointingly brief. So focusing on antimicrobial stewardship help to restore the efficacy of these drugs. Thank you.
Thank you, ma'am. I'm sure the audience will agree that the lecture was well planned, well structured, and the lecture was captivating. Madam has elaborated on the indications, efficacy, and also on the stewardship in her lecture. Any questions from the audience?
So for bloodstream infections, generally we use ceftazidime avibactam with or without aztreonam, sir. For intra-abdominal infection, tigecycline combination with one of the drugs which is available. If it is Acinetobacter, or then we can combine with minocycline. If it is Pseudomonas, what other drugs may be available, we can look into it. Then we can combine, not as a monotherapy. So this tigecycline, minocycline, colistin, these drugs should be always combined with the other drugs which is effective against something. So for colistin, again, we have to look into the penetration sites also.
Thank you.
Okay.
Now I would like to call upon our next speaker, Dr. Narayanan. Sir is a pediatric intensivist with experience of 20 years in PACU. He has 114 journal publications and 7 chapters in textbooks.
Very good morning to everyone. First of all, I'd like to thank the organizing team for inviting me. It's always a pleasure to come to Coimbatore, and especially being it's my wife's place, so I can visit my in-laws. Yeah. So my talk is a little basic talk. Okay. I'm trying to define what is sepsis. You've been listening to all hi-fi talks till now, including PID and multi-drug resistant organisms and also. I think it is a regression of milestones. Trying to define what is sepsis. But so my talk is going to be a very simple and basic talk. So let us try to see what exactly is sepsis. So what I'm going to do in the next 20 minutes is understanding of some terms like what is infection and what is sepsis. I mean, most of us think that we know this, but let us be very clear about it. Then history of sepsis definitions over the last 30 years or so. And what is the current sepsis definition? I think most of you will be aware that there is a current pediatric sepsis definition has been revised last year, February 2024. So we will discuss that. And what is it useful? Okay. So let us start with the case. As usual, we start with the case. So it's an 8-month-old infant who fever and cough for respiratory distress, and he has some tachypnea and chest introing present. His fever was 96, requiring on HFNC. So respiratory support is there. But his heart rate, respiratory, blood pressure and capillary refill time are normal. And so is this child in sepsis? That's the first question. Okay. So child has fever, everything, and requiring some amount of respiratory support. Is this child in sepsis? We'll try to answer this question at the end of this talk. Okay. Case 2 is also an 8-month-old infant who had fever, cough, and respiratory distress for 3 days. Tachypnea was there, but child has significant stridor, which we are not sure it's a laryngomalacia or some airway issue. So because of the stridor not responding to your steroids and adrenaline nebulization, required intubation. But after intubation, we found that even with an FiO2 of 25%, the child was able to maintain a saturation of 96. Okay, but he was stable hemodynamically, capillary refill time, everything is normal. Is this child in sepsis? Okay, yeah. So we'll try to answer that at the end of this talk. The last case is another 18-month-old child who came with fever for 5 days, some mild facial puffiness, tachycardia is there. A little bit of tachycardic, saturation 96, but requires an NRM, non-rebreathing mask. Blood pressure is 84 by 50 normal, but child has a mild thrombocytopenia. So maybe a little bit of oxygen supplementation and thrombocytopenia. Is this child in sepsis? Okay, fine. Okay, so we have these 3 cases. We'll try to answer these questions at the end of the talk. Hopefully, we'll be able to answer them clearly. So now let us come to what is sepsis. Okay, actually, it's a very old term. It is the Greek word "sepo" means "I rot." That means rot means you decay. That is the literal translation of sepsis. So this appears in the writings of Homer, Hippocrates, and all those great Greek philosophers and authors. So it's quite an old term. Even they say even Charagas used a similar term. They call it some Sannipata Jor. It's supposed to be sepsis. So this is a well-known entity. Sepsis has been there for almost 2,000 to 3,000 years. But most of us know when we hear the term sepsis, we generally mean this, correct? an infection which has gone out of control. Because we know infection, we know some idea. Sepsis is something more than infection. That's what we think it is. So we generally, what we understand is that a sepsis is an infection which has gone out of control. That's what our understanding is. So in layman terms, what do you mean by this infection gone out of control? So out of control infection can be two things. One is the microbe is overwhelmed the host. You know? So for example, suppose you have any any insult, suppose any fight, suppose you have an insult, the insulting organism can kill you. So that could be the thing going out of control. Or you might have overreacted. For example, suppose there's an insult in this room. Say the room catches fire. We can die out of the fire, correct? But some of us can die because we react abnormally to the fire. We can have a heart attack because we get scared, or I may go and run out of the window and fall and die. So that is called overreaction. So we can have adverse effects due to either the inciting agent being overwhelming us, or we can overreact. So the microbe overwhelming us is an easily understandable. That's easy to understand because all of us have seen cases with culture positive patients coming and crashing and dying within 24 hours, pneumococcal, meningococcal, all kind of culture positive patients coming and dying before we just give the first dose of antibiotics. So in them we know that the sepsis adverse event death is due to an overwhelming microbial infection. But we all know that we have a significant number of cases where microbe seems to be under control, but the child worsens. Classical example is, Dr. Balaji has been talking about dengue, so many cases he has shown. So many of these dengue cases, even he showed a case where even the fever has gone away, NS1 is negative, only antibody response is there. That means the virus has gone away, but child becomes sick and die, and goes into shock. That's what happens in dengue with, when it comes in a critical phase. The infection is over. So something else, that could be a host reaction. So has the host overreacted to the microbe? So mortality, what are the evidence for that? Sometimes adverse effects in sepsis because of host overreaction. Mortality even after giving sensitive antibiotics. All of us have seen. Culture has come positive, we have been giving sensitive antibiotics for 3-4 days, still child dies. Poor outcomes even after cultures are sterile. We don't find any organism, but still they die. Then secondary worsening like dengue, after elimination, they again worsen. So finally the moot question is, what we have to answer is, why only a small proportion of become sick and die with infections? Even dengue, if you see, all the people who get dengue, only a small proportion, less than 2% actually develop shock. Even all the children who develop pneumococcal infection, a very few go into shock or develop meningitis. Why that? So maybe there is a abnormal immune response. For example, suppose I scold all of you, I say abuse all the people sitting here on the front row. The reaction is different, so or no? The first person may cry, I get upset. The other person may shout at me. Third person may slap me. Fourth person may complain to the organizing team that this way has to be ejected. So the response to the host response is so much variable. So this we have to see. So when a child with infection goes sick, we used to think that it's the organism which is very, very virulent. But slowly we are realizing that the response to the host to the infection itself could be a major factor. So abnormal immune response to microbes could be a major factor. There is enough evidence for this. See, there are very high inflammatory markers in those patients who do badly, okay, which is disproportionate to the infection. There are enough references for that. In fact, all the inflammatory mediators persist for a long time. We've seen this during COVID, they start getting worsened after the 1 week of COVID. Then some of them have very low immune response. All of us have seen patients with severe leukopenia or low inflammatory markers in the presence of a severe infection. So infection can either overdo or underdo. Okay, even we have a term called cytokine storm also now, I'm sure, all the Bay of Bengal storms we know, but this is something called cytokine storm. Also we have, this is an excellent article in NEJ which came recently. So we all know that, the immune system can malfunction, okay. So there's a change in concept now. Poor outcome in sepsis may be due to abnormal host microbe interaction, specifically abnormal host response, okay. Correct? It could be a major factor in having adverse outcomes in sepsis. So strong possibility that when you have treated the microbe with appropriate antibiotics early enough, still patient doing badly, then abnormal host response could be an event. Now the problem is, if that is how to identify this host response, abnormal host response or abnormal immune response. And whatever, we cannot measure all those. When I showed you in the previous slide, all these guys have measured so many things in the blood, all the cytokines and all cytokine storm. That is not practical for us. So for us as a clinician, there should be something practical to use at bedside. Preferably some clinical or point of care test. We should be able to identify this abnormal host response. Okay, so that's what the sepsis definitions are tried over the years. Now let us go through that. What are the sepsis definitions over the years? So first of all, what do you mean by definition? So definition of a definition. Anybody knows what is the definition of a definition? What do you mean by definition? So that's the first question. So if you look at the dictionary, Merriam-Webster, it defines the definition as something that identifies the essence of a thing. That means the essence of a thing. When you say I define, say this mic, or define something, That means what is the essence of being a mic, or what is the effect of being, what is exactly you mean by sepsis? What is that essence of that? Okay. That is a dictionary definition. Or we can say what a thing is. When somebody says that, we immediately understand what it is. Okay. So let us see whether sepsis definitions have actually managed to do that. So sepsis was first defined in 1991 by this American College of Critical Care Physicians and Society of Critical Care Medicine conference in 1991. That is in adults. Then they have introduced a term called SIRS, which most of us are aware, Systemic Inflammatory Response Syndrome. We'll come to that later. Then it was revised in 2021 because there are multiple avatars. We are heard of Dasavadaram. So like the sepsis also has got multiple avatars. First avatar was in 1991. Second avatar came in after around 10 years. Then third avatar came in 2016. All these three avatars are for revisions, are in adults. When it comes to pediatrics, we have only two revisions. The first sepsis definition came in 2005, the latest one last year. All right, so let us quickly go through this. What are they? So sepsis 1, this is the first attempt to define sepsis. Okay. So this is the first report, came in chest in 1992, but the conference was in 1991. So they defined infection as two possibilities. One is presence of inflammation in the presence of a microbe. For example, just because you find a microbe doesn't mean there is infection. For example, if I swab my skin or my mouth, I get a lot of bacteria. Doesn't mean I'm infected, yes or no. But if I have a redness, swelling, and pain at the site, and then I identify organism, that means there is an infection. For example, in my mouth there is a gingivitis, and then I isolate the organism, then possibility. So inflammation in the presence of microbe is infection. But that doesn't mean that some sites were normally sterile, like for example, say CSF, or say blood, or say joint. If you find any organism, that's enough to produce infection. So one of these things has to be present. Then only we call patient as infection. The presence of microbe, inflammation, or presence of invasion of a normally sterile area by a microbe. So then SIRS is systemic inflammatory response syndrome. This particular definition they defined as presence of four of these things. Temperature, either high temperature or hypothermia, tachycardia, tachypnea, change in WBC count, either high or low. So out of these, any two are present, then you have systemic inflammatory response syndrome. That means your body is, the whole body is responding to some kind of infection. And so once they define these two, what is infection and what is systemic inflammatory response syndrome, presence of any two, they define sepsis as presence of these two. So infection plus SIRS, it's sepsis. Severe sepsis means infection plus SIRS plus some evidence of organ dysfunction. This was the first definition of sepsis, which is 1991, okay, in adults. So there's some problem here. What is the problem here is because these are highly non-specific. So no, suppose a child is crying. Child develops some, URI and crying means child have temperature will be there, tachycardia, tachypnea will be there. That means child is having SIRS. And some infection we identify, then the child is in sepsis. So this is highly non-specific. We know that burns can produce this, trauma can produce all this SIRS. So it is non-specific. So these guys defined it, wanted to change it a bit. So in the second avatar of sepsis in 2001, the infection was defined the same as before. They just mentioned it as either the infection can be documented or sometimes it can be suspected. For example, there are some situations where we need not document any organism. For example, you find a CT showing a brain abscess, or you have a ultrasound or a X-ray showing a bowel perforation. We know this is infection. We don't need to isolate the organism. So such things, the suspected infection without documentation itself can be called infection. They have further improved the definition of what is an infection. Then sepsis they defined as infection plus some of the following. See, they realized that SIR is very non-specific. And they looked at how actually a good clinician at the bedside, how he picks up a severe infection. So they put all these parameters, some 5 or 6 parameters, a lot of parameters including tachycardia, tachypnea, then mild respiratory distress, even increased fluid overload, then a lot of inflammatory variables. I'm not going to list off all that because it is very overwhelming. Some hemodynamic variables, organ dysfunction variable, tissue perfusion. So they say some of this following is enough. They don't even say how many. Some of this following plus infection is there now, it is sepsis. That's what they defined it as in the second avatar. And severe sepsis is when there is a significant organ dysfunction. Okay, so till this time, we didn't have a pediatric definition of sepsis. So in 2005, the first pediatric sepsis definition came in 2005. It is almost very similar to the adult definition. So SIRS is same, presence of one of those 4 things, tachypnea, tachycardia, elevated temperature, or change in leukocyte count. Only in pediatrics, they mentioned that out of these 2, one has to be either fever or leukocyte count. Not tachypnea, tachycardia is not, if you both of them, that is not SIRS, because any child crying can be having those 2. Infection is the same. Sepsis is same, SIRS plus an infection. and severe sepsis is organ dysfunction. Okay, so this is pediatric modification. The organ dysfunction, all they give some pediatric criteria. All right. Now, finally, the third avatar came in 2016, that is sepsis 3. Okay, this is an adult definition. Here, finally, these guys have defined according to the definition, no? Definition of a definition. Merriam-Webster's definition, they told what is sepsis finally, which we can at least conceptually understand. So this is the current conceptual definition of sepsis, okay? What is it? It is a organ dysfunction caused by a dysregulated host response to infection. So keywords is, there's an infection, then there is a dysregulated host response. Means the response is not appropriate, correct? It is not, say, something abnormal, either over or under reaction to the infection, and that can lead to organ dysfunction. So these three things are there, that is sepsis. This is the current definition of sepsis. This is easy to understand, no? An infection came, and the infection has produced some abnormal immune response in you. Appropriate immune response is there, you will conquer the infection. Since your response is not appropriately, it is going to organ dysfunction. Okay, so this is the current definition of sepsis. This is easy to understand. Now you understand what is sepsis, you know? Somebody says, this is the good definition of sepsis. I hope so. But the problem is, looks very good. But how to identify? Suppose I give you the definition, give you a patient, no? Fine. If you're wondering, I'm looking at the patient, no? And this patient does, you go and ask the patient, do you have a dysregulated response? Is a patient cry at you, yes or no? So you should know how to identify this dysregulated response at the bedside. That's important. So how to do that, they asked, nobody knew. So whenever we don't know don't know anything, no, and we want to find something, what we do? We form a committee, no? So an expert committee was formed. This committee was asked to look at how to identify this, dysregulated host response. So those guys also could not identify any good, a reliable test. So they went in a circuitous route. They told a dysregulated host response leads to organ dysfunction, you are saying. So organ dysfunction could be a good surrogate marker of this dysregulated host response. So then I can find bedside mechanisms for measurement of organ dysfunction. Then you assume that there is a dysregulated organ dysfunction. This is how they went. Okay. For example, suppose you went to Kutralam and taking bath. Suddenly, a lot of water comes. So you can always say that because of rain. So or no? So increased water is a surrogate marker of rain happening in the hills. So whenever Kutralam water increases, we know that there could be a rain. So that is a surrogate marker. Of course, it can also be because of a bunch of elephants passing urine, but unlikely. So like that. So whenever there is organ dysfunction, they assume that it's a surrogate marker of dysregulated host response. Okay, all right. So how to measure this organ dysfunction at the bedside? For pediatrics, the term we use is called Phoenix sepsis score. Phoenix. Do you know what is Phoenix? No. Many of you have read. Most of us think that Phoenix is, after reading all the Harry Potter stories, Dumbledore. We think Phoenix is that bird, which rises from the fire and all that. No, that Phoenix. No, this Phoenix is not that Phoenix. Okay, this Phoenix is different. This Phoenix is. There is a place called Phoenix in Arizona in US. So this conference was held there, and since the definitions were released in Phoenix in Arizona, it is called Phoenix definition. Okay. So here, the score, this is score. Okay, this is score. I will come to the score later. Okay, this is a table which is not very clear. I will go to the individual components of the score. So current definition of pediatric definition of sepsis is again same definition: a dysregulated host response to infection leading to organ dysfunction. So for their organ dysfunction identifying, they put 4 organ systems: respiratory, cardiovascular, coagulation, and neuro. And each organ system has given some points. Okay, calculate all the points and add together. The score is 2 or more. Then that is sepsis. Sepsis is more than 1. Sepsis along with 1 or more cardiovascular system point. That is septic shock. Okay, so it's very easy. Correct? So you have to just calculate the score, and if it is 2 or more, it is sepsis. So now let us see how to calculate the score. So there are 4 systems. So if you take a respiratory system, there are 3 points. So the respiratory system, you have to see only 2 things. Is the child on any respiratory support? What is the PO2 by FiO2 ratio if you do a ABG? If you don't have an ABG, you see SpO2 to FiO2 ratio. Okay, one of these things you need. And what respiratory support is it is. So score is 0 if the child is not on respiratory support and your SpO2 to FiO2 ratio is more than 290 or PO to FiO2 is more than 40. This is normal. Okay, then score is 0. Score is 1. If child is any respiratory support, just oxygen, score is 0. Okay, or if the child is on, and of course, if the PO to FiO2 is less than 400 or less than 292, okay. Then if child is on mechanical ventilation, if it is between 100 to 200 or SpO to FiO2 between these 2 range, 148 to 220, its score is 2, and 3 if it is less than that. These 2 are for child on ventilator. This child is on respiratory support. Any respiratory support is automatically assigned 1. Similarly, for cardiovascular, there are 6 points. It is based on child is receiving vasoactive medications, whether lactate is high, if you can do it. Or MAP. See, it's not necessary to do it. If you have, you do. Otherwise, we can manage the MAP also. So they given 3 of them. Okay.
So score is 0 if no vasoactive medication, lactate is normal, and the blood pressure they given ranges. This is for mean arterial pressure. They given ranges. This is above this for different age groups. Then it's 0. 1 point each of this. If one vasoactive medication, lactate between 5 to 11, and if the BP range is between these 3. Okay, this range for the age group. Then 1 point. 2 points if the 2 vasoactive agitations or lactate more than 11 or BP is less than this. That's it for cardiovascular. Okay, Phoenix. Then for coagulation there are 2 points. Platelet, any of the coagulation factor, whatever you are available, you do. You don't do everything. Okay, what is available, you do. If everything is normal, it is 0. If any one is abnormal, it is 1 point. But you can maximum have only 2 points. Okay, platelet less than 1 lakh, INR more than 1.3 and all that. For CNS also there are 2 points. You should need only GCS and pupils. So if GCS is normal, pupils reactive is 0. GCS is less than 10, 1. If GCS both pupils are fixed, it is 2. That's all. Very simple. Okay. So now a few practical points. Just another 2-3 slides. So the score may be calculated in the absence of some variables. That's important. You don't have to do everything else. You can calculate, still be reliable. Lab tests are at the discretion of the medical team. You don't have to do the test because it is given the score. Whatever you normally do, you do. The other things you can skip. Unmeasured variables contribute to no points. If you don't measure it, you don't use it. SPO to FA ratio is only calculated if the SPO is less than 97. But don't do it when the SPO is about 98. Use measured map, preferably, either invasive arterial or non-invasive. If that is not available, you can calculate map by this formula. Okay. Age is not adjusted for prematurity. And a neurological dysfunction can be used for both serrated and non-serrated points. So what the score means? Score is more than or equal to 2 means infection. Why they call it infection is because they found that the score is equal or more than 2, the mortality is 8-fold higher than children with just an infection alone whose score is less than this. So 7% mortality in high resource centers and 30% mortality in low resource centers. Septic shock is score more, the sepsis with more than 1 cardiovascular point score. Mortality is much higher, 10% and 35%. Okay. So what the score means that you identify a subset of children with infection who have higher risk of mortality, basically identify the sicker ones. So the term severe sepsis is no longer used because sepsis as such is a high mortality situation. So the severe sepsis is abandoned. Now we don't use that. Okay. So what are the common questions we can have? Why other systems are not in the score? Because no significant advantage. We are using only for people that tried adding more systems but doesn't make any difference. Can you use this score to identify those infections? No. We cannot use for infection screening. It's only for identifying sepsis. That means somebody who has a higher mortality due to infection. Only identify subset of children with a higher risk of death, not just infection. Doesn't mean we can abandon SIRS score. No, SIRS still may be useful at the bedside to identify children with infection, but you should know that it's non-specific. Okay. There are some merits. The merits is it's a conceptual definition. First time we have a conceptual definition. We have data-driven approach. They have used 10 hospitals, more than 30 lakhs patients for the development and more than 5 lakh patients for a validation. So it's a highly data-driven score. So it is very mathematically sound. It can be used for both high and low resource centers are being involved. There are some drawbacks, but all suspect infection may not be infection because some of them could be like pancreatitis or some kind of trauma and all that. Score assigns points for chronic conditions also. Suppose child has some chronic respiratory condition, that will be adding to the point. That's a minus point. And people usually mistake it for identifying infection. That's again a point which I want to stress. You can only identify serious infection, not just infection. Okay. And validity of science in the low resource settings is a concern still because number of centers, data from low resource centers were actually a bit less. And PICU heavy. Most of the experts were PICU people, so we don't know where they can be applied or not. That's it. So now we just, the diagnosis of those cases. This case is not in sepsis. Why? Because child has only 2 points. 2 points. Only 1 point is only a respiratory support. So this child is not in sepsis. Child is got a on HFNC. This child who is on ventilator still not in sepsis. Why? Because his FAO2 is only 25%. His score is more than 292. Okay. So this child also not in sepsis even though he is intubated. And this child is in sepsis because he's got 2 scores. One for oxygen support, one for low platelets. So this child is in sepsis. That's the answer. Thank you. The final word. We finally have a conceptual definition of sepsis, sorry. A life-threatening organ dysfunction caused by a dysregulated host response. That is a conceptual definition. Please remember this. This is an important definition finally we have in the last few years. But we don't know how to reliably recognize this one. So we use a surrogate marker which is the organ dysfunction. And this Phoenix score is the one to identify the surrogate markers. And we are going to have sepsis 4 and other iterations out us soon. Thank you.
Now I call upon Dr. Arun Kumar sir to hand over the memento to our esteemed speaker, Dr. Dhanalakshmi ma'am.
Yeah. No, because your question is what it will lead to. It may. In fact, it may be good because what the score says is that if the score says, especially in a low resource settings, the score is positive, 2 or more, it means the child has nearly 30% chance of death. The data says. So, I mean, suppose you see a child who's got a 30% chance of death, we like to treat the child differently, yes or no? So how to modify that chance of death could be, it need not always mean PSU admissions. That has to be a clinical judgment at the bedside. It may be giving the correct antibiotic in a child whom we are not actually thought of giving antibiotics. Maybe giving the correct antibiotic or draining a source. Okay, yeah. So it doesn't mean that patient has to be shipped to ICU. Patient has to be managed appropriately.
Thank you. Any questions from the audience? So where there's a will, there's a way. Dr. Dhanlakshmi and Dr. Narayan have shown us the way here. With newer antimicrobials and proper understanding of sepsis, we can treat pediatric infections more effectively. To conclude this session, I would like to say that we have to adopt one health approach, the interaction between humans, infections, plants, and environment, which leads to reduced antimicrobial resistance for better, optimum antimicrobial care. Thank you.
Thank you.
I call upon Dr. Arun Kumar sir to hand over the memento to our speaker, Dr. Dhanlakshmi ma'am. Sir, and also to Dr. Narayanan sir, please. Now I request our speaker Narayanan sir to hand over the memento to our chairperson Dr. Arun Kumar sir. Thank you, sir.
Thank you, chairpersons and speakers for the wonderful
Now
session.
I hand over the session to Dr. Sivanarayanan.
Thank you, Dr. Arun. So now we have the next session. So to chair the next session, we have a very distinguished chairperson, Dr. Sivanarayanan, consultant pediatrician and neonatologist from Shiva Hospital, Coimbatore. With over 25 years of exemplary service, he has been a driving force in pediatric healthcare, holding key positions in IAP, leading state-level pediatric events, and earning multiple awards for his leadership and community service. Our first speaker, the very insightful Dr. J. Balasubramanian, Associate Professor of Pediatrics at Sivagangai Medical College. Sir, we request you to please occupy the dais. Sir has been an active organizer of state pediatric conferences and a dedicated leader in IAP. He will be sharing his expertise on a very important topic, a topic of growing importance in child health, preventing food allergies in infants, and early allergen introduction.
Good morning, respected colleagues, distinguished speakers, and dear friends. It is my privilege to share this important scientific session, focusing on a subject that is more timing and critical, the impact of our environment of the health of our children. First speaker, please. Thank you.
Good morning all, respected chairperson and delegates. First of all, I thank the organizers of KONGU PEDICON for giving me the opportunity. The topic itself is the allergy, branch of allergy in India is in a toddler stage, I think. In that, the food allergy is in infant stage. I think so. The title per se is preventing food allergy, that is early introduction of food. But though I am practicing allergy, I have no experience in the title, the early introduction of food. By my speech, I fully referred in the literature only. There is no personal experience in early introduction. So if you see prevalence of food allergy, it is more in Western world. So in USA it is 8%, Australia is around 8 to 10%. But in India, it is very less, but lesser studies are available only. The recent studies done in Delhi and around Delhi is only 0.8%. That the rural is somewhat more. What are the common food allergens? Usually the food allergens, any food can cause allergy to anybody, but the common foods are, sorry, the picture is not displayed here. start on wheat, peanut, egg, shellfish and fish, sesame, like that. There's so many things are there. But the allergy can occur even before you take the food, because they become sensitized even before the intake of food. But directly it is not occurring. There will be a precipitating factor for food allergy in the form of allergic dermatitis, that is atopic dermatitis. It is considered as a gateway of the atopic march. It starts in the newborn period itself. Can occur in newborn period itself because they become sensitized in the newborn period itself. Then whenever the baby takes the food next time, the clinical manifestation can occur. So it is the atopic march starts with atopic dermatitis followed by IgE mediated food allergy. There are non-IgE mediated food allergy also available there. That is like a food protein induced enterocolitis, like that, and followed by respiratory allergy. So AD is the starting point, and there is, if it is severe, the risk for other allergies are more. So sensitization occurs even before oral intake of food. It is higher when the AD is severe, and the risk of food allergy increases with early onset, that is less than 1 month or less than 4 months, 1 to 4 months. The onset of atopic dermatitis is there. The risk for food allergy also high. It is due to the barrier dysfunction in the skin, which easily allows the allergen to enter in our body. What is the dysfunction in the skin barrier? The skin barrier is maintained by a protein called flagrin, which is the major protein in the corneocytes. It functions mainly to maintain the skin barrier and maintain the moisture of the skin. Whenever there is damage and the allergens can easily enter, whenever there is some even the touch or airborne allergen enter in through the skin and become and induce sensitization through the immune system in the skin, that is Langerhans cells, CD8 lymphocytes and dendritic cells. So atopic conditions rarely occur in isolation. So suppose one system is affected by allergy, the other system is most commonly involved. So multiple allergies will be there. Suppose if the skin allergy is there, food allergy and asthma, risk for food allergy and asthma also high. And one single food allergy is there, chances for developing allergies to other foods also high. And region wise it varies, depends on the food habits of the children and the culture of the and the customs of the food habits, it varies. For example, if you take Israel, their intake of peanut is high in early infancy itself compared to the UK and the US. So their early intake, because of early intake, they develop tolerance to the particular food, and the allergy to peanut is lesser, like that any other food. So some of the children are at high risk. When you say high risk, when the atopic dermatitis is early onset is severe, and family history of atopy is there, they are considered high risk children. And one food allergy is there, the risk for allergy to other foods also high. So this is the pathophysiology, how the children develop allergy. The allergen can enter through skin or through whenever we intake take place. So whenever you take the food, particular food, suppose it is a peanut, the proteins in the peanut, there is high amount of proteins are there, and so many antigens. There are about 10 antigens in the peanut, and antigens 1, 2, 3 are somewhat higher risk. They degraded by the gut enzymes and gut microbiota, and the broken down to peptides. Whenever they are broken down, the antigenicity is less compared to the entry through the skin. There is no system to degrade this, so they enter intact inside the body, so develop the allergy and immune response. So to say it is simple, even if you take a high dose of any food, they getting degraded, the antigenicity become lower, so tolerance is easier. But in the skin, they, even for the exposed low dose, they penetrate through the damaged skin as an intact protein with a higher antigenicity. So the allergic chances for developing allergy is more. So there are come guidelines by various professional bodies throughout the world. Until 2008, even the American Academy of Pediatrics suggested whenever you find or suspect there is allergy to any food, you don't give until 3 years of age. But the same AAP suggested this thing. In 2019, whenever there is high risk infants, that is child with atopic dermatitis, severe atopic dermatitis or early onset atopic dermatitis, the food should be given earlier, within 4 to 6 months. Mild to moderate risk after around 6 months or after 6 months. But if there is no eczema, depends on the family preferences and culture of these food habits, we can introduce the food. But the National Institute of Allergy and Infectious Diseases USA, they suggest whenever there is infant with high risk, do serum specific IgE and skin prick test in high risk infants. It is not possible to do a skin prick test in a severe eczematous child. The Australian Society, where the food allergy is high, they introduce the food during infancy. IAP, that is European Association of Allergy and Clinical Immunology, is a larger professional body. Whenever the population, the particular population having high prevalence of food allergy, first they advise introduce peanut as a complementary food, that is within 6 months. Canadian Society, the same thing, and they advise regular, even if you introduce earlier, they advise regular intake of food. What does our association, that is Asian association say? The same thing, the healthy infant after 6 months, higher risk, control the eczema. With at-risk children, don't delay the introduction of the food. So if we see some individual foods, the leader is the peanut. So I referred to some of the studies, larger scale studies. One of the studies is a leaf study and leaf pond study. Leaf studies are nothing but it was published in 2015. It is learning early about peanut by Professor Gideon Lack. It's a pioneer in the food allergy. This is a large scale trial. They introduced peanut in a high risk infant in 4 to 6 months of age. They observed decreased prevalence of IgE mediated peanut allergy even at 5 years of age, over 80%, compared to if you introduce the food after 12 months of age, there is higher risk of allergy. But this trial had no impact on the development of resolution or other allergic diseases like rhinitis or asthma. How they did? They given 2 grams of dried peanut protein 3 times a week before their first birthday, and they observed 80% relative risk reduction and a reduction in prevalence of peanut allergy by 3% in consumption group, but it was very high, that is 17% in avoidance group. How it happens? Generally, any antigen entering our body, that is peanut, they either through gut or skin, they recognized by the antigen presenting cells, and the antigen presenting cells give it to the T cells, the T helper cells, T helper cells. The T helper cells release some interleukins which stimulate the B lymphocytes. B lymphocytes secrete IgE. Did IgE go and attach the mast cells? Whenever the next time, whenever the antigens introduced in our body, these antigens attach with the Fc receptor of IgE and release some histamine-like substances from the mast cells. They produce symptoms. But here, what happens? Once they introduce the food slowly and earlier, there is some modified Th2 response that instead of production of IgE, the IgG4 is synthesized, which was an immunologically inert substance, which will not produce any clinical symptoms. That is the technique, pathophysiology behind this. So oral tolerance induction to peanut is associated with increased production of specific IgG4 against peanut and the inhibition of specific IgE against the peanut antigen through a modified Th2 response. This IgG4 is constitutes 5% of total IgG in our body, It is a unique structure which induce tolerance and non-inflammatory. It competes with IgE in binding with antigen, like a competitive antagonist with compete with IgE in binding with allergens and produce no response with allergen. There is no complement binding, which is a part of a pathophysiology in the allergy clinical response. The same thing was done in another trial with the egg. They introduced egg as a powder form in 6 to 12 months. We advise after 9 months only here. But by 6 months they observed a significant reduction of developing egg allergy. Same thing in milk. It is not a trial, it is observation in Israel. And early exposure to cow's milk may prevent later development of CMPA. They observed 13,000 infants without discouraging the exclusive breastfeeding. Whenever the child was introduced formula milk based on cow's milk by first to 2 weeks of age, lesser allergy to milk than if started after 3 months of age. And one other study was done by introducing multiple foods, 6 allergenic foods, that is peanut, egg, cow's milk, fish, wheat, like that. And they are divided into 2 groups. One group at introduction at 3 months, another at 6 months. And they given at least 2 grams of each food protein per week without decreased rate of breastfeeding. This is the main thing. And they found this is the not significant results, only 20% reduction in early group. So various studies and various results. See, a major outcome of these studies are sensitization occur earlier and lesser, and a serum specific IgG4 is synthesized, which induce tolerance and inhibition of high level of specific IgE to the particular food. So importance of regular injection by advised by the Canadian Society, both early introduction and regular injection of age appropriate amount at least once a week likely to be useful to establish a tolerance and maintain it. Whenever there is occasional or single exposure, it could be a detrimental result in increased risk of sensitization allergy. So regular injection we maintain giving a booster dose for a vaccine. Regular injection of any particular food may induce tolerance and may prevent from food allergy. So if regular injection is not feasible, that is not custom in the food habits of the community, better to avoid the particular food item from weaning. The ideal amount and frequency is not established. So already some of the studies were done in food allergy prevention, starting from the antenatal period itself, suspecting something and intervention like the using probiotics, prenatal antibiotics, and avoiding environmental pollution. And vitamin D now largely used in newborn itself and some by allergy in the field of allergy also. And there was a paper that the cesarean section, babies born by cesarean section were at higher risk in developing allergy, but normal delivery children are lesser allergy, like that, so many things. But they found out something that DHA in a part of polyunsaturated fatty acid may have some anti-inflammatory effect. Human milk oligosaccharide, they have some immunomodulatory effect. Vitamin D and prebiotics and probiotics, they are being used as supportive treatment in the allergy conditions. But they are in large scale trial only, that is the evidence is not fully established. So these are all in investigation stage only. But my point in preventing food allergy than early introduction of food is, if we effectively treat and control atopic dermatitis, we can prevent some food allergy. But selection of steroids, this is one of my dermatology friend advised these things. Selection of steroid in control of atopic dermatitis is an important one, and depends on the area of involvement in our body. We have to select the steroids, that is face and genitals, desonide and hydrocortisone, arms and flexures, F for efulticosone, legs and back, mometasone and beclomethasone, and they advise avoid using clobetasol and betamethasone. So, and some severe forms, we can use some steroid sparing drugs, but better to get opinion from the dermatologist and select the drugs. So, selection of drug for a particular area is important, and maintenance of treatment in controlling atopic dermatitis is important in prevention of future allergy. So, my message today's talk is atopic dermatitis is considered as a gateway of early atopic march. Consider optimal control of atopic dermatitis as a mean of preventing allergy sensitization and treat it effectively, which may prevent future food allergy. Early introduction of allergic foods and regular intake in individuals with high risk, that is severe eczema, family history of allergy, may help to induce tolerance and to maintain it. Even you stop the drug, stop the particular food after that, the tolerance is maintained. But it is very much needed now is the food habits, based on food habits for our community in our country. We have to do large scale studies and advice regarding that. Thank you very much.
Excellent and elaborative talks by our speaker. Any question and answers from the audience? Yes, nextly I would like to call upon the next speaker, Dr. D. Balachandar, on plastic pollution and child health.
First of all, let me thank the organizers and the Tamil Nadu state chapter leaders for giving me an opportunity to present this an important topic. This topic is not for your daily practice, but for your children and for your grandchildren. So today, in the next 20 minutes, I'll be dealing with regarding plastic pollution, where India stands, different types of plastics, the exposure, the effects on the environment and children, and how a solution for this and some strategies for prevention, mitigation strategies. So, is it a real threat? So, plastic pollution is a global issue, and killing wildlife, contaminating our oceans and waters, and lasting for longer than it's used. So, this is the various scenarios we see nowadays in railway stations, railway tracks, streets, burning lot of plastics producing greenhouse gases, and it's a threat for the climate change. So it's a real threat. So this global environmental crisis is because even though it is plastic is made from the fossil fuels and with a high carbon footprint, producing a lot of greenhouse gases and producing climate change, and this problem with the plastic is that it will remain in there for years, for up to 500 to 1,000 years, and unfortunately only a tiny percentage is only recycled, even in rich countries. This plastic leaches into the food and drink, and it causes hormonal disruptions and cancers. And once it remains in the ocean, it will pollute the ocean and kills the marine animals, and through the seafood it will enter our body. So the children are most vulnerable group because it is due to their smaller size, developing organs, and increased head-to-mouth activity. So friends, plastic is found in water we drink, the food we